Just a minute.
Hello,
Hello?
excuse me. I'm sorry.
Yes.
I would please request you if you can make also the recording, start the recording from the Kahoot, so we can view the Kahoot in the recording. Even if we cannot interact or answer, it will help us for training and to get, because, you know, if we cannot attend the live session, this was the first time to me to see the Kahoot.
See, actually, whatever is there in the Kahoot is actually repeat of the class. So there are no questions which is not explained in the class. Okay. If you study the class, you will get all the answers. There is nothing extra special in the Kahoot.
Yeah,
Okay,
I
Kahoot is
understand,
for practice.
but
If you are
practice,
not there, then who will be practicing? Okay. So from next day, please join Kahoot. Okay. Let's start with the ultrasound guided caudal epidural and sacroiliac joint injection. So today, actually the day when we will be discussing on both. That means today we will be discussing on the ultrasound guided caudal epidural as well as we will be discussing on the sacroiliac joint injection. And we will be explaining both in the CR and in the ultrasound. So let's see how we can perform. So what are the basic anatomical knowledge? As we are not yet done the CR part, so I'll be discussing in detail here regarding the anatomical portion. So we all know this sacroiliac joint and we know about the caudal epidural. So sacroiliac joint is a synovial joint in the lower part and fibrous part is at the anterior part. And here it is a joint formed by the sacrum with the ilium. So if we see in the model, first let me take the model. So, okay. Just a minute. Okay. So now, education. I put it like that. The model is in front of you. So here, what you can see, these are the iliac bones, and it is joining with the sacrum, and sacroiliac joint is the joint formed by these two bones. Now, remember, when we see under the ultrasound, we see only the top portions. When we see under the CR, we see both the posterior joint lines as well as we see through the bones. That means we see the anterior joint lines as well. Okay. So when we'll be seeing on the CR, we'll be seeing both anterior and posterior joint lines. So first, I am going to demonstrate the ultrasound. So I am not going into the detail of that. But in the ultrasound, what we'll be able to see, first for performing the procedure, one important note is that this structure. What is this structure? Anyone?
Spine.
PSIS.
Posterior superior iliac spine. Okay, and this roughly corresponds in the S2 foramina here. Okay, so here you can see this posterior superior iliac spine corresponds with the S2 foramina, and here goes the S2 spine. So for doing ultrasound guided procedure, this is an important landmark that if we put the probe in this plane, then we will be able to see the landmarks like this. I'm holding it like this so that it is easier for you to understand how it will look under ultrasound. So at the central portion, there will be the spine. Okay, so this will be the spine. Then after the spine, there will be a down portion. Okay, and we all know the ultrasound doesn't goes behind the bone. So here we will be seeing the bone only, this area of the bone. Next, what is there? This is a nerve root, S2 dorsal nerve root. So here we are getting the S2 foramina. And as we come to the center, we will be able to see the spine. So these are the important structures that we will be able to see at the level of the S2 if we put our probe like this. Now, if we go below, then this portion will change, because here if we see from this angle, so it is a undulating spine, and then it is the depressed portion. So there will be heights as well as lows. So as we'll be going down in some distance, this spine we won't be able to no longer be able to see the spine. Then further we'll be able to see this depressed part, and then we'll be able to see the bone. But in these sides there also be sacroiliac joints. Now as we go down, we'll be reaching the other foramen. So when we reach the other foramen, the light again, the ultrasound waves again pass through that foramen. So we'll be able to see that foramen. So in this session, if we go in the transverse view, we'll be able to see these structures. Now, if we go further up, then what will be there? Up to the S1 level, there is no canal. Okay, so no posterior dura. As we cross it, then we'll reach the L5, but before that, there the ultrasound waves will dip, and then we'll be able to see this bone, okay, the anterior portion, okay, that is the posterior part of the vertebral body. So today the lumbar spine is not in our scope, so we are not going into detail of the lumbar spine. We have next module where we will be talking on the lumbar spine, but for the sacral area, I'll be showing up to this. Now, if we grow along the longitudinal axis, then here if we put at the center or midline, then we'll be able to see the spines. Now, if we move up, it will be a continuous up to the S1. Then there will be a gap. Again, the echoes will pass through it. Then we'll be able to see the L5. Slightly, if we go laterally, we'll be able to see the foramens. So this is very simple if you know that how the bone is. That is why I am showing you the model. So this part is clear. Next, we are
Yes, sir.
yes, sir. Okay. Next, we are moving to the how it looks on the ultrasound. Okay. So here okay. Here you can see this is the iliac bone, and now this is the portion of the sacroiliac joint, and here lies the posterior sacroiliac ligament. Now, next it is over the bone, then again it goes to the S2 foramina. So if you are able to see the here echoes will pass through this. Next, it will be reflected from here in this area, then we'll be able to see the spine. So this contour we need to follow, and we need to find out. Please mute. Please mute over the sacrum so that we can find out the sacroiliac joint. Now, as we all know that when we do the sacroiliac joint block under fluoroscopy, we see from the contralateral oblique side. So again, that will be shown today after this class in the CN part. But in the fluoroscopy, we do from the contralateral oblique side. Similarly, here we'll put our needle from this side, contralateral oblique side, and then we'll reach to this area. And here lies the posterior capsule. And with the needle, we need to, this is the posterior capsule, and here with the needle, we need to pierce this posterior capsule, and then we'll be reaching the sacroiliac joint. But remember, the evidence says that if we give injection in the sacroiliac joint and the perisacroiliac area, that means periarticular injection, both works. It is not only the intra-articular injection, but periarticular injection is also having evidence for the sacroiliac arthropathy. So what we commonly do, we inject some amount of drug inside the sacroiliac joint, then we come out here, and then we give some amount of periarticular injection, and then we remove our needle. So this is what will be shown under the ultrasound. I'm not going into detail because I'll be showing this part in the patient. So this is the spine. Then this is the S2 foramina. You can see the ultrasound reaching equiwaves going down. Then again the bony part of the sacrum. Then here comes the sacroiliac joint, and this is the iliac bone. So this structure we need to find out under the ultrasound. And in this area, we need to put our needle. So this will be the needle direction for the sacroiliac joint injection. So that was all. So first I am showing the sacroiliac joint injection in the volunteer. Then I'll be showing you the injection. So let's stop sharing. বলো বেরিয়েছে আসেনি, চলো আমরা তো শুরু করে দিই। এই তুমি প্যান্ট প্যান্ট খুলছো ঠিক করে, আমি দেখো তোমার দেখা যাচ্ছে। Okay, now. Okay. So here I'll be showing you in both the probes. I'll be first showing in the linear probe, because in linear transducer structures are much clear, but sometimes for the ultrasound guided injection in the sacroiliac joint, we need to use the curvilinear probe. So there is no harm using both the probes, because curvilinear the resolution will be less, but in the curvilinear probe we will be able to see more amount of structures. Hello. Previously I was talking with the computer speaker. Now it has changed. So am I audible?
Yes, sir. You're audible.
Yes, sir.
Okay, good. Because
Yes, sir.
in the I talk in the computer speakers microphone, then the problem is when I am too near the patient, you won't be able to hear clearly. So here first I am selecting the probe. Here I am selecting first the linear probe with the musculoskeletal mode. Fine. So can you see? So first, what I am doing, I am palpating the PSIS. Then I am putting the probe. All right. So now you can see so just I have put it here. I do not know which the exact area, but I have put it, and the picture what you can get is this. So here most probably this structure is the S2 spine. Okay. So what I have used the word most probably, because to confirm whether it is S2 or not, here I have gone with the PSIS, the location. That's why I did probably, but you have to count it as well. So this is the spine, and here this is the ilium. This is the sacrum. remember, here the previous picture of what I have shown, in that picture, what you have seen is that this area, some rays are, echoes are coming like this and some echoes are going like this. But here you are not able to see this because this is not the exact location where we have put it. So we have to, after putting this, we have to go slightly superior or slightly inferior. So if we move it, then we will be able to find out the exact location, whether we are near the S2 or not. So here again, I am, so but the spine you are able to find out, na? Are you all clear about the spine?
Yes, sir.
Fine.
Yes, sir.
Because it's a basic course, I am going from the basic, because otherwise
Yes,
it may
sir.
be difficult for you. So now I am again diffusing and I am at the center. So I think you can see or now, because again the hand is obstructing the probe location. So but the problem will remain the same if I only possibilities. Okay. So there is no way actually. একটু এদিকে আসবে, আমার দিকে আসবে, আমি তাহলে এই প্রোব এটা ওদিক থেকে দেবো, তুমি এদিকে এসো, আমার দিকে আরো চলে এসো, আরো চলে এসো। Okay, fine. Okay, so I have changed the position of the camera so that my hand will not obstruct it. So again we are at the center. So at the center and at the level of the posterior superior iliac spine, we are able to see the spine. Here we are at the center. Now, as we move up, you see the spine is vanishing. Okay, so here you can see a clear spine, but as we move up, this is the loose, that is the depressed areas. So here we are not able to see the spine. Then we will again able to see the spine, but in between this depressed area, no echo is going below. So this proves that we are on the sacrum. We are not over the gone to the cross the S1. So our assumption, what we told, that when we are at the PSIS level, then we are at the S2 is correct. So again, we are moving to the S1. Okay. After the S1, so this is the midline at the level of the S1, and this is by the side. Again, first I am going through the midline. Now, here there are two ways. Okay, one is to toggle the probe, you move the probe up and down. Another is the changing the direction. Okay, but remember, we need to, it is better that we follow one thing. That means we should move up or down. So here at this level, just a minute, I've gone much up. Just so we first check in the midline. So this is where the, so here the left side of the screen is the towards the cranial side. So as we move up, see, up to this level, okay, the level towards the right, echoes are not going in, but just at the above level, echoes are going down. Okay, echoes are going down. So here it proves that we have crossed the area of the sacrum, because here we are able to see the spines, and in between the spinal echo, the echo is going down. So this is the lumbar area, This one is the S1 and next one is the S2. Now again, we are coming to the same area, aspect marker towards the lateral side and towards the left of the patient, and we are back at the PSIS level. Now I am going lateral. So in this level, can you see in two areas the echoes are moving down? This is actually better demonstrated. Stop. See, this white portion is the bone. This is one foramen and this is the sacroiliac joint. But this is better demonstrated because the echoes are diverged in the curvilinear probe. So they are better demonstrated there. So I am showing this in the curvilinear probe as well. So again, we are finding the PSIS, putting it. Okay. Now we need to change the depth so that you can see it in a large size. Now we are coming towards the left side. Now can you see in two areas? Now it is very much clear which one is the sacroiliac joint and which one is the S2 foramina and which one is the spine. Clear? Dr. Chinamara has drawn for you. So I think this is very much clear about the sacroiliac joint. Now if we see the longitudinal view at the midline with the curvilinear probe, again the same thing. That means at the top there is the aspect marker. So the left side of the screen is the cranial side. So here at the midline we will be able to see the spine, but here you will need a very stable hand and you need to see it, because what happens with a slight movement of your hand, the probe moves. So see here you are able to see the spines. Now if we go slightly lateral, again we are over the bone, and again in this bone you see in the some areas echoes are passing down. These are actually the foraminas. Now if we go further lateral, then again we will be very close to the sacroiliac joint, but in this view it is very difficult to locate the sacroiliac joint. You can check your needle, but this is the best view for doing a sacroiliac joint procedure. And the needle direction, you can draw the needle direction, will be like this. So that's all. And let me show you one video of the sacroiliac joint injection. Now regarding the theory, I think already the evolution of low back pain, the class is done. Yesterday, last class sir has already shown that how the sacroiliac patients with the sacroiliac joint pain will present, which patients are prone to sacroiliac joint pains, and these basic things. So let's stop in share and let us show you one video.
Hello, sir. Can I ask one question, sir?
Yes.
Sir, the first our anatomical landmark for this should be the PCs, posterior superior.
Yes, that is the easiest. You can take other landmarks also. Okay, you can come and from the midline go up, then you can do. But this is the easiest way to first get the PSIs, then go to the medial side. That is the easiest way.
Okay, sir.
Okay, let me show
Thank
you the video. Okay, here we are doing ultrasound guided sacroiliac joint injection. So first we are trying to focus the here. This is the sacroiliac joint. You can see where my probe is. Sorry, my cursor is, and here when the rays are coming like this, or not rays, but sound waves are coming like this, these are actually the S2 foraminals. So first we are injecting local anesthetic in the skin. We have seen, and here remember we should go from medial to lateral side. So this is the local anesthetic. Usually 1% lignocaine is injected in the skin and subcutaneous tissue. Lagbe. SIN package. Okay, here the patient is a little bit obese. So the problem is, if it is a very lean and thin patient, then you can see the needle better because the angulation in those cases is slightly less. But here, the other technique is using a USG compatible needle or moving the needle. So here you can see while I am doing the procedure, I am continuously either rotating or moving the needle so that the tissue in the area moves to see. This is the needle. Okay, here is the needle. So I am moving it slightly because in those cases the tissue movement is helping me to visualize the needle better. So this is this much we have already entered. This is the tissue movement you can see, and that is where my needle is. So I am going toward, this is the S2 foramina, this is the sacroiliac joint. I am going towards the sacroiliac joint. I am very close to the capsule. Just over the capsule, and here in this area when we are over the capsule, there is a feeling of cutting the capsule, and that we get in the USG as well as the fluoroscopy. In fluoroscopy you have an advantage that in fluoroscopy you can give the dye and you can check the dye spread, but in ultrasound that is missing, that you don't have a dye, so you cannot check. So again I am confirming the needle position. Okay, so after this we need to put the drug. Okay, so removing the stellate. And here in sacroiliac joint, as the needle is not, tip is not visualized inside the joint, so there is no point if you give it under vision or not, hardly matters because you are not able to see the tip. Okay, in areas where you are able to see the distension or you can see the fluid, in those cases definitely you can do it with the ultrasound as well. So that is what was the sacroiliac joint injection. And next, okay, how much volume? Usually 2 to 3 ml in the sacroiliac joint is good enough. But if you want to give the periarticular injection,
Hello,
then
sir.
what we give is a 2 to 3 ml in the sacroiliac joint, then come out and then inject the rest.
Hello,
Yes.
sir.
Yes,
Sir, I'm not clearly understand.
you are not clearly understand what.
Sir, this sonogram, ultrasonogram video is I am not clearly understand. It is SI
Okay.
joint.
I am showing it again.
Oh, thank you, sir.
Actually, the problem is you are able to understand the sacroiliac joint, but you are not able to see the needle because the patient is a little bit obese. If the patient is a lean and thin patient, then it is easier to view because in those cases, the most of the rays will return back. But here, the problem is the rays won't be returning because the angle is near 45 degrees. So we need to move on the movement of the tissues. Okay. So can you appreciate the joint now?
Yes, sir. Yes, sir.
Okay.
Now I can
So-
see. Yes, sir.
Okay. Let me.
Okay, sir.
So this is the joint. Clear? This
Yes,
is the
sir.
foramina, and this is the
Okay,
spine.
Okay,
Okay.
thank you, sir.
Okay. Thank you. Sure. Okay. So let's move on to the sacroiliac joint injection. So for the sacroiliac joint injection, I don't have a, sorry, not the sacroiliac joint, but the caudal epidural injection. So I don't have a video, but I'll be showing the successive images from a video because unfortunately the video is not here today with me, but it will be almost similar to a video there because there are multiple images, successive multiple images. So let's first again going back to the sacroiliac joint area. Okay, so when we going for the sacroiliac joint area, the most important anatomical landmark is the sacral cornu. So let's see again in the bone where we need to go. So for those who are from the anesthesiology background, it is a little bit easier for them to understand because they have already done, especially in children. But remember, doing in children is much easier than doing it in adult. So let's see how this can be possible to do in adults. Remember, don't try other positions in adult. The most commonly it is done in the prone position. So the positions that we adapted for the children is not a good position here. So first look at this. So here the lower sacral laminas are not fused. So instead they form these sacral cornus. And here from the, you can see S4 and S5 unfused. You can see S3, S2 and S1. So if we see the same from an angle like this, so here we will be able to see two sacral cornus. We'll be able to see two sacral cornus, and in the cross section, we'll be seeing the same. So these are two sacral cornus, and here you can see the bony portion here in the below part. And this is the important landmark because from this area we need to insert our needle. So we have located, then we have moved slightly up. Then we will be able to see this area. So instead of showing the pictures, let us see it all on the patient and not patient, the volunteer. And another important thing is that here we will be checking from this side also. Okay, so if we see the longitudinal view, so what we will be able to see? We will be able to see a break because in this area we will be able to see it is reflecting from a echo is reflecting from a higher angle, higher side. But as it goes to this part, okay, that is the posterior portion of the vertebral bodies of the S4 and S5, then it will be reflecting from a lower part. So you will be able to see a step in this area. So, and we need to appreciate that step for performing a ultrasound guided caudal epidural. So let's share. So again, here, if the patient is lean and thin, it is usually done with the straight probe or the linear probe. So again, so first I am taking the linear probe for this patient. So I am changing the probe. Here is the linear probe. Musculoskeletal I have chosen. Now, can you see what I am doing? I am first going in the same way. So aspect marker towards the lateral side, towards the left of the patient. And now from the area, okay, let's start from the same area where we have started. Okay, so I have moved up towards the S2. Now we are moving down. Okay, so now it is the S3. Now as S3 is gone, okay, we are no longer able to see any spine. Instead, we will be able to see a step, okay, a depression. Okay, so let's reduce the depth so that you can see it clearly. So let's take it at the center. And now we are able to see the sacral cornu, and you can see the echo reflecting from the posterior portion of the vertebral body of S4 and S5. We do not know which level is this, but either this is S4 or S5, and you can see the white bony area in between these sacral cornus. So here is the area where we can see the posterior part of body, and these are the sacral cornus. Now, for performing the procedure or for putting the needle, we need to go to the longitudinal view because we'll be coming from below. So we'll be doing it longitudinally. But before that, again, I am coming back to area. So it is very clear to you. Okay. So first PSIS, then we are going medial. We can see the S2. Then we'll be seeing the S3. Then again, there is the depressed portion. Then suddenly I'm slowly, gradually moving from above downwards. So see S3, then S3. Let me increase the depth. I think depth is 1. I need to focus it around 2 so that it is clear, more clear. Okay. So now it is gone, gone, gone. Now there will be no roof. Up to this area, there was the roof of the lamina of the S3. Now here, as I going down, we have lost the roof. So now we can see the posterior part of the body. Now we are coming down, see how beautiful is this. This is the S5 level. Almost we have gone down, and up to the S5 level, we can see clear sacral cornus, and we can see the lower portion. Okay, I think there is no confusion here, and we are going further down. Okay, and then we'll go to the sacrococcygeal area where the cornus are lost also. But we are not going that part. For our injection, that much is not required. So in this area, what we are doing, we are from the transverse, keeping it at the center, we are rotating the probe to 90 degrees so that the aspect marker will be towards the cranial side. So our head will be towards the left of the screen. Cranial side will be the left of the screen. So now I have moved. So this is beautiful picture and beautiful ultrasound. You can see the step. All right. So here what you can see, this is the S3. Okay, this is the spine. Now this is the upper table and then it becomes the lower table. And in between this is the sacrococcygeal ligament. What I am drawing, so let me take a different color, that is blue, and this is the sacrococcygeal ligament. So while performing, we need to pierce this sacrococcygeal ligament and we need to go in with the epidural needle. Here, most commonly used is the epidural needle. And then we need to inject. But here I should say that while performing the caudal epidural under ultrasound, you should always remember that ultrasound in caudal epidural has an important drawback. And what is that drawback? That drawback is, so that drawback is, can anyone say what is the main drawback with the CM?
Eye test.
The needle tip cannot be seen.
Yes, the needle tip cannot be seen and we cannot give the contrast agent because ultrasound don't have that much of that contrast. But we get the omnipaque or IFX12, whatever we get in case of the CM guided procedures, that is absent here. So here that is a big disadvantage for us. So in those cases, in these procedures, we usually prefer to use a fluoroscope inside of ultrasound if there is no contraindication for the fluoroscopy for that patient, because ultrasound helps to guide the needle towards the sacral hiatus and past the sacrococcygeal ligament. But fluoroscopy helps to determine whether we are intravascular, whether I have gone much interior, whether my needle has gone intrathecal, or it is perfectly at the epidural space. This because this information is lacking with the ultrasound. So in this regard, fluoroscopy is better for these procedures. So let's again come back to this pictures. So this is the area that is above that I have already shown, that here our echo waves are deflecting from the top. Now this is the picture and here you can see the sacrococcygeal ligament here, and we need to pass our needle in this direction. Now you can see first local anesthetic is being injected and you should choose a point after, so that slightly below, so that if you choose very close, the problem is again the needle will not be able to view the needle very clearly. So we need to choose a point that is slightly lower, and this is usually merges with our usual point what we take for the injecting the under fluoroscopy. So after local anesthetic, we need to take a epidural needle, and with the help of, you can see the epidural needle, we need to go in and we need to pierce this ligament. Okay, now we are at the level of the sacrococcygeal ligament. Now we have pierced the ligament and my needle is up to this level, and this is where our ultrasound guidance ends. Ultrasound can no longer guide us after this place. So now we have changed. So if you have fluoroscope, then it is always better. And if there is no contraindication for fluoroscopy, check under the fluoroscope. It is clearly in between two tables and you can see our needle is in the epidural space. You check in the epi view as well, and it will be at the level of the S23 junction or at the level of the S3 if you want to be still safer, and then inject the dye. Here already the dye is injected, so you can see the inverted far tree appearance of the dye. Okay, so here this is the top of the, and here you can see through the foraminas these are coming. So this is very important to know how this spreads would look. So if it is a vascular spread, then we will be able to see only under continuous view because it vanishes. It is inside the vessels and blood takes the dye away. So there will be the vanishing sign. And if you for momentarily, you will be able to see the venous structures, that is the tortuous structures here. And most commonly it is inside the veins. So we have to rule out that dye spread. So if that is the dye spread, we need to reposition our needle. And if you're doing with the epidural needle, then the chances that is going inside the vessel is less because the vessels are very small here. And if you are needle using the smaller needle, smaller gauge needle, the chances is more. But what usually commonly used is the epidural needle. So chances 16 or 18, most commonly the 16, then chances of going to the vessels is less. Now we are injecting the dye. Now epidural spread has a very characteristic appearance that is heterogeneous. That is coming out to the foramen. Please mute if someone is talking, requesting them to please mute. Please mute. Okay. So it is the heterogeneous. So see, it is not homogeneous. Here it is more, here it is less. It is coming out through the foramens. And these are important that you will be able to see the structures. And then here in the caudal, there is the very important inverted fat appearance what we will observed. And now we have to inject the steroid injection. Okay. And for the caudal and lumbar area, most commonly what we use is the particulate steroid, the triamcinolone commonly used. So usually up to 5 to 10 ml of fluid is, or the steroid is injected, and usually 40 to 80 milligrams steroid is injected through that. And then we should take out the needle. So that was the ultrasound guided caudal epidural. So I think if you, it is most of the confusions what you have with the ultrasound guided injections is clear, but still if you have any questions, you can ask me. Yes.
Sir, how about just putting the injected inferior to the acoustic shadow, not go into the sacral canal? Because no barrier between the hiatus and sacral canal. So if we input the sacral hiatus, it will still go to sacral canal.
What you want to do? You want to inject inside the caudal epidural. Okay, you are going to do a epidural injection. Fine. And here you and what you want to do, that how you, my question is how you will differentiate whether you are inside a vessel or you are in the epidural space.
I mean, just put in sacral hiatus, because if we go
if you put
the
in the
sacral canal, we can
hiatus,
see the niggle.
If you put in the sacral hiatus, then what will happen? Your drug will mostly come at the lower side. But for what we are doing? We are doing because most commonly it is the L4-5 or L5-S1 disc lesion, discogenic pain, and your drug will not reach that area. So there is, what is the point of giving the injection for the sacroiliac joint injection here? Sorry, the epidural injection here, because in those cases the drug will not reach to that area. And even when it will reach, you have to use a large volume of drug. Then to increase the concentration, you have to use a more concentrated or more dose of steroid. So that is not required.
Sir, I have a question.
Yes.
Sir, what is the volume of caudal epidural?
Okay. For the pain, usually 10 ml serves for the L4. Here, mostly we commonly give for the L4-5 and L5-S1 level. For the other levels, usually transforaminal is preferred. And here, usually 10 ml is the total volume, that is preferred volume.
The concentration of local anesthetics is it 2% or 1%?
It depends on when we want to discharge a patient. Okay, if you are going like us, what we most commonly do, it is under the daycare procedure. So in daycare, if you give more concentrated local anesthetic, we have to keep the patient more time in our clinic. We have to follow up more. but our local anesthetic is not our prime thing. That means we don't want to give a temporary effect. Rather,
Yes,
our
sir.
more important is the effect of the steroid. So here, usually for me, I used 2 ml of this local anesthetic lignocaine and dilute it in 10. So it becomes even less, okay, 1/4, more than 1/4 dilution, so that we can discharge the patient, in time. And more concentration is not required. So 1%, 2% is not required.
Okay, sir. Thank you, sir.
5% or even low is good
Yes.
enough.
Thank you, sir.
Sir,
Welcome.
sir, again, sir, if we still 20 cc and put in sacral hiatus only, not in sacral canal, you mean it will go to
Then-
L4 level, sir?
Then what will happen? Most of the drugs will come out through the foramina of the S4, S5. Okay, it will come below. And to reach the L5 or L4 space, then what you need to do? You need to give more volume and to increase the concentration. If you give more volume, that will be more diluted. So you have to use more steroid. So here our target is going to the more specific area, not good doing for much dilution.
Oh, okay, sir. You mean better in sacral canal, sir?
Not in sacral canal, okay, not below, because our main purpose will not be served.
Thank you, sir. Thank you, sir.
Hello, sir.
Yes.
Sir, I want to ask one question that, sir, is there any chance of developing any transient weakness following this caudal epidural injection?
See, transient weakness after steroid is, with the steroid, it doesn't occur commonly, but with local anesthesia, if you give in a higher concentration, the patient, there might be a weakness that usually lasts for 1 to 2 hours, but it is self-limiting. So it doesn't cause us a problem.
Sir,
Yes.
another question, sir. While once if we do not have a fluoroscope and we only have the USG, so where should we stop? Like once it pierces the sacral.
I should say, if you have only the USG, I am not in favor of doing caudal epidural under USG. Because the main thing, that is whether we are inside the vessel or not, that we cannot determine only with the this thing, with the US ultrasound. And where our needle tip is, whether it is intrathecal or not, we cannot determine. Okay. So in those cases, I think it is better to avoid the ultrasound. It is better to do under fluoroscopy.
Sir, hello, sir.
Yes.
Sir,
Sir,
one
any
last question,
advice
sir. One
after discharge in caudal epidural for patient?
I could not get the question. Okay.
Sir, any advice after
Okay,
discharge?
definitely. We should give the proper advice. So what are those advices that is commonly asked to the patient? First of all, the patient should be accompanied by some other person. The patient should not drive while going back home. Next is that there might be some amount of weakness for the initial few hours, so that should be taken care. And most commonly, we do not discharge if there is weakness. We keep the patient in observation and we check whether he is able to go to the toilet and he is able to walk properly or not. Then only discharge. And then we should give the advice if the pain increases or pain towards the tingling numbness occurs in the emergency ward, we should we should give the reception number as well. And in emergency ward to contact, ward to come, that is very much important. And this is the usual advice. And post discharge, usually if you are doing a very sterilized area, then it is fine. But in India, it is not that thing. So we use antibiotic a little more. That is not good, but still we use. So we give it a little bit antibiotic coverage as well. We give this paracetamol, usually 1 gram for 3 times a day for the 5 days for the procedural pain relief. So this is commonly advised to the patient. And the medications for which patient was taking, like gabapentin or preventive, what is there, that should be continued because the effect is not immediate. And so for that time being, these drugs should not be stopped.
Thank you, sir.
Okay.
Dipjyoti boss, there is someone who asked about the where to stop in the caudal. Please mute yourself. I think there is someone who is unmuted.
There is a dog barking.
Yeah, dog barking.
Okay.
Very loud.
Okay, if you look at the recent guidelines for the caudal epidural, what Debjyoti boss said is the best. Okay, if you have a fluoro, that is like, you cannot have a substitute of that. But still, if you want to perform caudal epidural ultrasound, the recent guideline says that this is the sacrococcygeal ligament. As soon as you pierce it, stop. Do not go, beyond that. And the other thing is, like, when you are injecting, you can put on the color Doppler and you can look for the you will be able to see the movement. Color Doppler is like, it will be sensing the movement. So that is the another thing which you can do if you do not have a fluoro. Okay, but still, if you want to perform the caudal epidural, as soon as your needle will pierce, because you will be able to see it under ultrasound when the needle is piercing the sacrococcygeal, stop there. Do not go beyond that. So that is the safest one, and if you'll see, it is also there in the literature. So if you still want to go for it, you can go for it like that. So that was something.
That is another question. Actually, few things now. When we are in anesthesia, we were in anesthesia. That time the thing was very simple, but when we come to pain, because the things become very difficult. Okay, so there is a question that in children we do. Yes, I have also done in my post-graduation training. I have also done in children with a simple intramuscular needle. We have gone to the caudal epidural for the caudal epidural, and we give for the post-operative period. Yes, we have done that. But the thing is, when we came to pain, now after that, when we injected under the fluoroscopy, and number of intravascular injections we have seen with our needle placement is really, really high. So the confidence of doing it without the fluoroscopy and without seeing the dye spread, I don't have that confidence, because I have seen in many cases, okay, when I didn't know these things, then I used to do like that. But in many cases, it goes to the intravascular place, okay? So especially if you are using a finer needle, the going to the intravascular space is very high.
Do you use a preservative-free lignocaine or the one with preservative?
Definitely we use preservative-free lignocaine, not only here, okay, in most of the procedures except for the joint injections and skin subcutaneous tissue, we use the Xylocard.
Okay, so here you would take 2 ml of
Xylocard.
0.2% and then dilute it in the whole
Dilute it
into
in
10
it.
ml.
Yes.
Yeah.
That is the role of epidural catheter. See, for the pain management, for the chronic pain management, this epidural catheter, how long you can keep? Because the patient is suffering from years, from months. So here the role of epidural catheter does not come. See, in fact, in most of the cases, we do not use the epidural catheter. Next is pro-con debate in the. Okay. Okay, fine. So I think most of the questions are answered. Is there any question left for the SI joint? Okay. Linear probe have a straight footprint, and the USG probe will be have a square curvilinear footprint. The current image will be like a pot. Okay. Linear probe have a, yes. The linear probe, definitely the footprint is straight, and the curvilinear probe, it goes like this. So it will be like that only. Okay. So the logo of the USG machine in the. Okay. So most of the answers, I think Dr. Kanchan has answered the questions in here. Okay. So I think it is the time. So we move on to our next part. Let's. Sir is there? Hello.
Yes, I'm here. I'm listening.
Okay.
As muted.
Sir, I think you can start now. We'll be changing our setup now towards the fluoro.
So are you not demonstrating caudal epidural under ultrasound?
I have already demonstrated.
Caudal epidural?
Yes. Yes, sir. Now question answer from where on caudal epidural?
Okay. Can you all see my slides? Yes.
Yes, sir.
Okay. So in between, I'll be asking you some questions. So please unmute yourself and answer it. But otherwise, keep yourself muted. When you'll be answering or when you'll be asking question, please unmute for a brief period and then again mute yourself. Right? Okay. So first is X-ray. X-ray, CT, and MRI. These are the three most important kind of image in the spine. And out of this, MRI is obviously the most important, which gives you the maximum information. But because MRI is costlier, so we are not always advising MRI unless it is very much important. So this is also important to learn and to understand that when we should order an MRI and when we should order an X-ray, when you should order an CT scan. So I'll be talking a little bit about CT. I will be talking a little bit about the X-ray and some of the basics of MRI. We can understand in a class of 40 minutes. It is very difficult to explain everything about the MRI. And not only that, MRI is such a thing. I will be asking you the best way to learn the MRI is go and see as much of image as possible. Look and look and look more and more you'll be developing the ideas. All the images will be stored in your hard disk of your brain, and gradually you'll be able to correlate it better. So coming first to X-ray. So what are the things which you can make a diagnosis? So the other things which you can, and a little bit about these few terms. So spondylitis, what is it? It is basically a layman term. No, either you should call it a spondyloarthritis, or you should call it an ankylosing spondylitis. Something like only spondylitis term is more commonly used as layman persons. But if it is a spondyloarthritis, definitely there are lot of signs of the spondyloarthritis. We'll be coming to that subsequent slides. What is spondylosis? This term is very important because many of us, particularly those who are in the the basics, so these terms are confusing. So I just try to clarify this. So second term is your spondylosis. So first term is a vague term used by the lay people, should not be used by a doctor. So spondylosis is a term, means degeneration. Degenerated spine is called spondylosis. So which part? Again, spondylosis is a vague term. Spondylosis is the degeneration, and degeneration of any part of the spine. It can be disc, it can be facet joint, it can be different other ligamental structures, calcification, osteophytes, irregular margins. So everything in the spine is called spondylosis. And another very important thing we have to remember, the spondylosis is a radiological diagnosis. It can be X-ray also, you can call it spondylosis. MRI also can show you the spondylosis. CT scan also can show you the spondylosis. And it is very common that you'll be seeing this term spondylosis, spondylotic changes in the image, any of the spine image. And do not blame spondylosis as a cause of the back pain. Last day we have talked. We have to be very specific in our understanding the pain generator. That means which structure of the spine is actually generating the pain. We should have a very clear idea about that. And for that, spondylosis term is not a specific one. Spondylosis means degeneration of any part of the spine. Then another term is spondylolisthesis. What is it? One vertebral body is slipping over the other is spondylolisthesis. Will be again, this can be clearly diagnosed with the X-ray. We'll be coming to this. Spondylolysis. Spondylolysis and spondylolisthesis many times can coexist. Spondylolysis means fracture of the pars interarticularis. We'll be showing you. So that also can be diagnosed with the X-ray, and some other fractures as well, like fracture of the vertebral bodies. So this can also be diagnosed with the X-rays. But to have a better idea, we can have particularly the bony landmarks, the architecture of the bone are better understood by CT scan. So going to the next slide. So this is okay. So please, some of you, please unmute yourself and tell me what is this image? Is it the image of spine? So is it an AP view, or oblique view, or lateral view? AP view.
AP view, sir.
Okay, very
AP
good.
view, sir.
Of lumbar. Okay, what is this one?
Pedicle, sir.
Very good. What is this two?
Lamina.
Lamina. Very good. What is this three?
Spinous process.
Sinus process.
Sinus
Very
process.
good. What is this four?
Transverse
Transverse.
process.
What is this five?
Superior articular.
Five?
Inferior
Inferior
articular
articular
SAP,
process.
SAP.
Inferior articular process. What is this six?
Parts interarticular.
Very good. Seven?
Superior
Inferior articular.
facet joints.
Inferior articular process.
Yes, yes.
Inferior articular process. See here, superior
IAP.
articular process is this one. You know, this
Yes,
is
sir.
superior articular process. This is AP view. That's why it is not very nicely saying. This is the inferior articular process, and that is becoming lamina. So inferior articular process is gradually becoming lamina,
Lamina.
right?
Yes,
So now what
sir.
is 10?
Yes, sir.
Interlaminar space. Foramen.
Interlaminar space.
What is this 11?
Interforaminal space.
11?
Transforaminal.
Intervertebral.
I'm showing my cursor. What is this triangular piece of bone?
This mammillary body.
Superior articular process.
Superior articular process.
Above the superior articular process is a foramen. So where to where is the foramen? From one pedicle to another pedicle. From here to here is your whole of this is your foramen. So foramen is not just here. It is from here to here. And what is this 12? Inferior. So this is an AP view. You have to remember the X-ray is basically, it's, you know, we have seen the Tom and Jerry picture, you know, we are putting it and making it 3D structures into 2D structure. So it is like that only. If you are, you know, making it flat and making a 3D structure into 2D structure, then it becomes like that. So it is superimposed. Anterior, middle, posterior, all structures are superimposed. So what is important that in your brain, so you have to convert this 3D image into an 2D image. So sorry, 2D image into a 3D image to understand which structure is which structures, because there is overlapping. Anterior structures, posterior structures, they are overlapped. Like say for example, so it is looking like a circle, isn't it? Pedicle is looking like a circle, but is it a circle really? Pedicle? Pedicle is nothing but a pillar.
No.
But when you seeing a pillar in a tunnel vision, then it is looks like a circle. Okay. Now let us see in the lateral view. So see, this is your pedicle, but when your serum beam is coming like this, then this pedicle looks like a circle. So now tell me, here there is no marking. So what is this?
Vertebral
Body.
Very good.
What's your body?
Pedicles.
This is pedicle. I'm just showing you the circle. What is this circle?
Transverse process.
Very good. It is transverse process in tunnel view. Like, you know, when you are seeing the pedicle, you see here, the pedicle is looking like a circle. And transverse process is looking like a rod.
Yes.
Okay. So now when we are going in this view, now pedicle is looking like a rod and transverse process is now looking like a
Circle.
circle. Okay. And what is this? This triangular piece of bone?
process.
Very good. What is this?
Spinous process.
Inferior articular process.
Inferior articular process. Very good. Okay. Now look at this image and tell what is the unusual thing in this image.
Sir,
Extra lumbar vertebra.
Extra lumbar vertebra.
What is that called?
Sacralization.
Lumbarization.
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 So when S1 is converted into a lumbar vertebra, it is called lumbarization. So one extra lumbar vertebra. And when a lumbar vertebra is converted into a sacrum, it is fused, then it is called sacralization.
Sacralization.
Right? But is it possible that the 12th rib is absent?
Yes, sir.
Okay, so that is also a possibility. So number one possibility is that
Sacralization.
there is a lumbarization, and number two possibility is that there is 12 is absent here. So now looking at this image, what is the most likely? Is it a lumbarization or is it a 12 rib absent?
So 12th rib is absent in this patient.
Why?
Sir, because 12th
It
rib
will be floating, sir.
Floating rib, sir.
Sir, it is floating rib and it's very short.
Any other thing? You see, this is again very important. Whenever you'll be doing any procedure under image guidance, and you all know this, but if you are joining this line, two line of the iliac crest, through which level it should go?
Number 4 vertebra.
L4.
Sir, L3,
Lower
L4.
border of the L4.
At the L3, L4.
If you are
Lower
drawing
border
this
of the
iliac
L4.
crest, it should go between L4 and L5. That means this is L4, this is L5. Now count. This is 4, this is 3, this is 2, this is 1. Okay, that means most likely the 12th rib is absent here. It is maybe rudimentary here. Okay, very small rudimentary kind of things. So otherwise, if you still have the confusion, then what you should do? You should count from the cervical one. That means you should ideally have, particularly in the MRI, what they do, they count their whole spine image is there. They count from above to below and they mark in that way. Otherwise, lumbarization, sacralization, absent 12 breath, everything is possible. So to understand which level is which one, because all these things determine your treatment outcome. Where you are finding, okay, I am planning to go for a L5 selective nerve root block. So unless you understand exactly which one is L5, you can't do it nicely, right? Now look at this. What is this image? X-ray, CT scan, or MRI?
X-ray.
X-ray
X-ray
lateral view.
lateral view.
Lateral view.
Which part? X-ray of head or tail or what?
X-ray lumbosacral spine lateral view.
Okay, AP view or lateral view or oblique
Lateral
view?
view.
Lateral view, sir.
Okay, so what can you see? Okay, just tell me, which is this vertebral body?
L5.
L5.
Why L5?
The last
We can see the
this is
sacrum
Just-
below.
Just
Superior
above
to
the
sacrum.
sacrum.
L5, S1.
So if I am telling there is lumbarization or sacralization, how can you confirm that it is really L5?
Finest process.
Again, the iliac crest. You see, the iliac crest is going like that. Can you see this iliac crest? So iliac crest normally corresponds to L4-5.
L4,
This is at the level of the L4-5. So most likely this is your L5, right? Okay. Now tell me what kind of abnormality you can see here.
Increased disc space.
space.
Reduce disk space in the
Okay,
L.
very good. So this space, if you are comparing this space and this space is reduced. Anything else can you see?
Osteophytes.
There is sclerosis, marginal sclerosis of both vertebra, L5 and S1.
Okay, so can you understand that this space is looking darker than this space?
Yes.
Degeneration.
That is known as vacuum sign.
Right. That means
Vacuum
here
sign. That indicates
there is gas.
reduced space.
There is gas generation in the disc. So what is this gas? Nitrogen gas. And it is one of the surest sign of the disc degeneration. So by X-ray, you can say the disc is degenerated by looking at the two signs. Both signs are here. Number one is if the disc height is less. Last day I discussed it. Can you remember? What are the functions of the annulus? Annulus function is to maintain the disc height.
Height of the vertebral column.
And when we talk that this disc is degenerated, which part of the disc has three parts? You can remember. One is annulus, another is nucleus pulposus, another is end plate. So now degeneration of the disc starts from
Yes.
annulus. And one of the features of the annulus is if it is degenerated, then it will be buckled. It will be buckled. It cannot give the disc height. So the disc height will be reduced less. Okay, that is one of the surest sign. And second sign, which can be understood by the X-ray, is your presence of the gas shadow in the disc. That is called vacuum phenomenon. That is called vacuum. It's really not vacuum, but it looks like vacuum. It is actually a nitrogen gas. Right? So by X-ray, if I'm saying, can you understand disc degeneration in a plain X-ray? Answer is yes. So what are the surest sign of the disc degeneration on plain X-ray? Number one is reduced disc height, and number two is vacuum phenomenon. Okay, some of you are actually, please, what I told you, please remain muted. Only when I'll be asking you questions, please unmute yourself that time. Okay, otherwise it will be very difficult to, because of so many noises are coming. Okay, now another questions. So I'll be again asking you. One, what is it?
Transverse process.
Okay, first tell us what is this view? AP, oblique.
Oblique view, Scotty dog view.
Oblique view, sir.
Very good, very good. So one is your
Transverse process.
Transverse process,
Pedicle.
inferior articular process.
Superior articular process. Very good. So you can see the superior articular process is best seen in the oblique view, not in the AP view. You see here in the AP view was there. In the AP view, superior articular process is very faintly seen, and it is overlapped with the inferior articular process and other structures, so you cannot see it nicely. Whereas, please unmute when you'll be talking. Then only please mute. So here in this image, you can see the superior articular process is very nicely seen. So to see the superior articular process, to see the facet joint, you can see the facet joint also very nicely opened up. So in the oblique view, the facet joints opens up. So this is your superior articular process, this is your inferior articular process, and this neck of the Scottish dog is what?
Inferior articular process.
Part articularis.
So if there is a fracture there, that is called
Spondylolysis.
very good. So fracture of the pars interarticularis is called spondylolysis. And spondylolisthesis can be because of, one vertebral body is not stripped over the others. Why? Because of the presence of the facet joint. Facet joint, superior articular process, inferior articular process, one is concave, another is convex, and they are giving the stability of the spine. So one vertebral body over the another vertebral body is not slipped because of the facet joints. So now spondylolisthesis, how it happens? There are two possibilities. One possibility, if the facet joint is grossly degenerated, the capsules are lax, it cannot hold, then one possibility. And second possibility is if the pars interarticularis is broken, if there is a fracture, then also there is chances of spondylolisthesis. So spondylolisthesis can be either congenital, or it can be because of the degeneration of the facet joint, or it can be because of the fracture of the pars interarticularis. Right? Okay. Now look at this. Here you can see the pars interarticularis also can be seen in the lateral view. And you can see this is the fracture. So this is called spondylolysis. And that is leading to spondylolisthesis. So this is, advanced anteriorly. So this is also called anterolisthesis. Okay. When it goes posteriorly, then it's called posterolisthesis. So this is spondylolysis. So here you can see the pars interarticular structures. But remember, pars interarticularis fracture is best understood by the oblique view. But in the lateral view also you can understand. And oblique view it is best seen. So again, here you can see the lateral image of the spine. One is with the normal image, standing. Second, B is your with a flexion of the spine, and C is your extension of the spine. So now let us talk a little bit about the spondylolisthesis, why spondylolisthesis can cause pain in us, and what are the classification of the spondylolisthesis, and when we should refer our patient to a surgeon for operation. Okay, so look at this slide very, very nicely. So first important message to you that whenever you'll be getting a patient of spondylolisthesis, always have an flexion extension image. Why? the flexion extension image tells you whether the listhesis is a stable one or unstable one. What is the meaning of stable or unstable? When the listhesis, you see here, the listhesis means, this line and this line. So this is moving anteriorly. So you can see how much is moved here. So how much? If this part is less than 25%, this is called grade 1. If this part is between 25 to 50%, this is called grade 2. If this is between 50 to 75, this is called grade 3. If it is between 75 to 100, means this part is completely coming here, then it is called your grade 4. And if it is completely separated, not a single point is touching, then it is called grade 5. Right? Grade 5, grade 4 normally seen only in the accident cases, not in the normal degenerated cases. So now, when we are having a spondylolisthesis, we should understand, grade is important, but more than grade, what is important is whether listhesis is a stable one or an unstable one. So one is we see that the flexion and extension, see here is a flexion and see how much, and see here is the extension and see how much. So if this changes, then we call it unstable listhesis. And unstable listhesis needs to be fixed by plate and screw. But if the listhesis is stable, you need not have a fixation surgery. So remember always, if you're having a listhesis, have a lateral image of X-ray, have a flexion extension image, and try to understand whether this is a stable one or an unstable one. Another very important things to remember, that what happens, what are the clinical features of the listhesis? So if the one joint is moved, one vertebral body is moving over the other, so what is happening? The load is over. What is preventing? Facet joint. So what will be the load? Load will be on the facet joint, because when once is moving over the other, facet joint is trying to hold it here. So here is the facet joint. So here is the facet joint. So this facet joint will be getting loaded, and that will be causing the pain. So in listhesis, the back pain is because of facet joint. So if a listhesis patient presents to you, which is stable, which is presenting with the back pain, so what you can do is your facet joint intervention. That will be giving excellent results. But other thing is also possible. So what is that? That this canal, central canal, all this neural foramen, they are also getting narrowed. You see, here is the neural foramen, here is the neural foramen. So this is called, if the central canal is narrowed, that is called central canal stenosis. Last day I discussed. So this is a bony stenosis. If it is because of disc, that is by the soft tissue stenosis. But when the listhesis is there, that causes a bony stenosis. And if that produces a neurodeficits, damage of some of the nerve roots, then that is another indication for the surgery. But not all the patients with the listhesis presents with the neurodeficits. But some patients might be presenting with the neurodeficits who are again candidates for the surgery. So remember, from this slide, take home messages, always have an flexion extension image and try to understand whether the listhesis is a stable one or an unstable one. Now, this is again very important. What you can see here is a sacroiliac joint image. And as we were discussing at the first slide, that spondyloarthropathies. Spondylitis is a vector. Inflammation of the spine is better called as spondyloarthritis or spondyloarthropathy. And spondyloarthropathy is a basket of disease. There are several diseases like ankylosing spondylitis, like psoriatic arthritis, reactive arthropathy. So these are all your different types of spondyloarthropathy. So in that spondyloarthropathies, the sacroiliac joint is the most important joint which is getting involved. So radiologically, you should search whether there is an evidence of sacroiliitis or not. So that can be understood either by the X-ray or by the MRI. MRI is more sensitive, but more costly, obviously. But X-ray also is important. But another very important message to understand, that sacroiliitis on image and pain on that patient may not match all the time. So in around 50% patient, they do not match. That means sacroiliitis is there, but the patient is not having pain from the sacroiliac joint. and vice versa. Means sacroiliac joint pain is there, but sacroiliitis feature is not there. So what is the importance of this X-ray of sacroiliac joint? Importance is to classify whether the patient is having spondyloarthritis or not. So whenever you are having a patient or your provisional diagnosis is spondyloarthropathy, there are different other criteria. This is not a class for the spondyloarthritis. So how to remember is you must be having an image, either X-ray or MRI of sacroiliac joint. So here on X-ray radiologically, so sacroiliac joint has 4 grades of sacroiliitis. First one is mild sclerosis, grade 1. Grade 2 is more sclerosis, and there is some erosive changes. Grade 3 is bilateral erosive changes or unilateral, the severe erosions. And grade 4 is complete fusion. So complete fusion sacroiliitis is important, very important for SI joint, but complete fusion do not produce any pain because already fusion is there, no movement in the sacroiliac joint, so pain might be reduced. So that is what I was telling, that the pain and sacroiliac joint sacroiliitis may not match, but still sacroiliitis have value in diagnosing, in classifying the spondyloarthropathies. Moving to the next slide. This is again taken from our own patient. You can understand here, you can see the sacroiliac joint is completely fused. You cannot see the joint. So this is grade 4 sacroiliitis. So now coming to the CT scan. CT scan is basically one step ahead of X-ray. CT scan also uses the X-ray beams, but here it is a lot of multiple from the different angles. So here CT scan is important to understand the bony architecture, particularly when you are having a fracture. To understand better the fracture outlines and to understand the bony spinal canal stenosis, like just now I told you in the spondylolisthesis, if it is a bony spinal canal stenosis, then CT scan is better than the MRI. If it is a soft tissue like disc, like ligamentum flavum hypertrophy, then it is obviously the MRI is better. But when we are having the bony spinal canal stenosis like a spondylolisthesis, then CT scan is a better. Or if you want to have a degenerated spine or calcifications, or when this is also last indication is also important indication that in some patients there is metallic implant, which metal is not compatible with the MRI. So in those situations also we are forced to do an CT scan. So now you can see the bony structures are better understood. So can you tell me from which level it is taking? Is it to the vertebral body level or to the disc level? This section, transverse section, is
Disc
from
level.
vertebral body or
Disc level.
Disc level. It's from disc level.
Why?
Intervertebral
Foramen
Facet
not
joints
clear.
can be seen.
Facet joint is visible.
foramen is visible.
All these are true, but simpler answer is you can see here the bones is looking so white, but here it is vertebral. If you know the vertebral body, it would have been looking more white, isn't it? But other things you told that okay, you can see the foramens and other things is not the pedicles. So please mute. When you be answering that time only unmute. So this is at the level of the disc, and you can see the superior articular process. Superior articular process is always from lateral and the inferior part. Inferior articular process is from the medial, and as I told, inferior articular process is gradually becoming the lamina. So here is the lamina, right? Now here what you can see,
Collapse of the vertebra.
it is a fracture. It is a vertebral fracture. Okay, so vertebral fracture is, in the basic class we are not going into the detail of the vertebral fracture. Just to give you some basic idea about the spine. So the spine have, by the Dennis classification, vertebral body has vertebral spine. Sorry, our spine is classified in the 3 column. Anterior column is from anterior margin. Anterior longitudinal ligament is here in front of the anterior margin. So anterior longitudinal ligament, anterior 2/3 of the vertebral body, anterior 2/3 of the disc. This is your anterior column. So this part is from here up to from anterior longitudinal ligament up to the anterior 2/3 is your anterior column. Middle column is posterior 1/3 of the vertebral body, posterior longitudinal ligament, posterior part of the disc and annulus is your middle column. And here is your posterior longitudinal ligament. Anything posterior to that, that means whole of the spinal canal, the pedicles, the spinous process, and all the ligamental structures, the ligamental flavum, supraspinal, interspinous ligament, all these are the posterior part. And remember, the posterior column is the most important because it is having the ligaments which gives the stability of the spine. So the spine fracture classification, I'm not talking here, but you have to remember that whenever you are having a fracture, the best way to understand the fracture is having both CT scan as well as MRI. The bony structure outline is best understood by the CT scan, and the ligamental structures, ligamental fracture also is important, and ligamental structures fractures are better understood by an MRI. So again, you can see here it is also anterior column. You can see anterior column fracture. Anterior column is from here to here, and also there is middle column fracture. Okay, so this type of fracture is also called bust fracture. Okay, so this is another. What is this? This is a schematic diagram. This is called CT discography. So when you put the dye inside this disc and see how much it is leaked, if you can remember that disc degeneration, it is always starting from the inner layer of the annulus. So please mute.
Sir, you
Okay.
please make me co-host. I got disconnected.
You are host.
No, actually, I got disconnected. So again, you are the host. So,
Oh my God. Okay, let me just let me check. Okay, fine. So here, when you are, as I told on the first day, or the other day, that the inner layers are first degenerated in the degenerated disc, inner layer of the annulus. So if the annulus has the 2-3 functions I told you, if you remember. One is maintaining the disc height, other is holding the nucleus pulposus, because nucleus pulposus is gel, having a lot of fluids inside. So there's a natural tendency to leak, and if the disc is degenerated inner layer, so nucleus pulposus starts leaking. And depending on how much the nucleus pulposus is leaked, that is telling you what is the grade of degenerations. So if it is the inner 1/3 like this is your grade 1, and this classification is called the modified Dallas classification. If it is coming up to the middle 1/3, this is called grade 2. If it is coming up to the outer 1/3, then it is called but there is no circumferential spread, then it is called grade 3. If it comes up to the outer 1/3, but along with that, there is a circumferential spread which is more than 30 degrees. Means if you are having a center point here, and if you are looking 1 point and 1 point, so if this angle is more than 30 degrees, if it is less than 30 degrees, that means circumferential spread is very minimal. In that situation, it is classified as the grade 3. But if the circumferential spread is more than 30 degrees, that is called grade 4. And if the disc is coming outside, thereby piercing all the layers, then it is called grade 5. So grade 0, grade 1, grade 2, grade 3, grade 4, grade 5. And this is best understood by the CT discography. So first inject dye inside the disc, and then having CT scan, and then you can classify the disc degeneration. And here, so here is the CT discography. So you can see this is normal. You can see here it is. Which grade is this? Please unmute and tell me.
Grade 3.
Grade 3, very good. Grade 3, because it is coming up to the outer layer, but no circumferential spread. So this is your grade 3. What is this grade?
Grade 4.
Grade
Very
4.
good. So here it is also coming up to the outer 1/3. No leaking outside the annulus, and it has a circumferential spread more than 30 degrees. So it is your grade 4 disc degenerations. Very good. Okay, now come to the MRI. So MRI, the other conditions, particularly the soft tissue structure of the spine, are best understood by an MRI. So all these things can be understood by the MRI. Now, for the MRI, we have to understand that this is a black and white structure, And which structures, like in the bone or CT scan, which structures look white? It is the bony structures. More calcified, more bone, the X-ray cannot penetrate, so it looks white. And which structure looks black? Why the X-ray penetrates. So here also we have to understand that the which structures looks white, which structures look black in MRI. And MRI have the different kinds of MRI. So T1 weighted image, T2 weighted image, STIR image, contrast enhanced image. But mostly we have to understand that T1 and T2. So in the this is depending on the orientation of the the ions. We are getting the different kinds of image. But when you'll be having an MRI plate in front of you, so there will be T1, T2 written on it, or sometimes STIR. STIR will not be supplied to you unless you advise for it. So now you have to understand that on T1, which structures looks white and which structures look black. So in T1, fat looks white, and where there is no fat, it looks black. And which structures looks gray in between black and white? If there is some fatty tissues, that looks gray, not totally dark, not totally white. So depending on the amount of the fatty tissue, structures will be looking either bright white or it will be looking completely dark. Now see at the T1 aortic image. So this is looking very bright white. So what is this white structures?
Subcutaneous tissue.
Subcutaneous fat. Very good. And then you can see these are the the structures. These are the structures which is looking gray. But again, in between, you can see here is a very bright white structures. So what is this bright white structure? This is your epidural fat, posterior epidural fat. So this is also looking white. Okay. So now here, this is a vertebral body. Vertebral body has the bone marrow, and bone marrow again have a lot of fats. So this is also looking whitish, but not as white as subcutaneous fat or epidural fat, because this is pure fatty tissues. Here a lot of other things are there. Here there is some marrow, blood vessels are there, and other structures are there. So it is not, it is gray basically. It is not white, not black. Now look at here. This is your CSF, and this is your having very minimal amount of the fat, so it is looking black. Look at the disc. In between the two vertebral bodies, disc. Here also there is no fatty structures, so this is also looking black. Anterior to that, there is some fatty tissues. In the abdomen also, there are some omental fats. So these are looking again little bit of white. Is it clear? So T1 weighted image, you see which structures are looking white is the fatty tissues which looks white in T1. Now T2, both water as well as fat looks white. And which looks black? Where there is no water, where there is no fat, that will look black. And the structures which will be having some water or some fat will look gray. Right? So now look at here. So this is looking white. Why?
Subcutaneous fat.
Fat, because in the T2 also, whatever structures looking white here, they are also looking white here, because fat will be looking white both in T1 as well as T2. So this is posterior fat is also looking same white. This subcutaneous fat looking same white. But additionally, the CSF, which was looking black, is looking white, because it is water.
Water content.
It is also looking white, right? And STIR is called fat suppressed image. Here, only water will be looking white. Fat will not be looking white. And where there is no water, will be looking black. So here you see subcutaneous fat, they have been suppressed. Epidural fats, they have been suppressed. They are not seen. Only thing which is looking white is your
CSF.
So this is the basic thing you have to remember. So now you tell me, looking at this image, which one is T1? Which one? Okay, first tell me, what is this? T1 or T2 or STIR?
T2, sir.
Sir, STIR first.
Why?
No, sir.
Sir, because
T2, sir.
What?
STIR.
the water element that is
STIR.
Oh, no, sir.
and the disk water is white in color.
So this is STIR
This is
because
T2.
you see the epidural fat. Epidural fat is getting suppressed. Here you see the epidural fat here and epidural fat here. Epidural fat is getting suppressed and CSF is
sir.
looking white. So this is your STIR. This is
E2.
T2.
E2 because
E2,
both
sir.
CSF as well as fat is looking white. And you can see there is some fatty infiltration in the spinal canal. And this is pathological and that is getting suppressed here as well. And this is your
T1.
T1.
You can see all the fats are looking very bright, right? So this is one of the very basics of the MRI to understand what is T1, what is T2, what is STIR. It is clear to everybody, I hope.
Yes, sir.
Okay, let me skip these slides. Let me go to this first. So this is again another very important thing. That means the images are taken, slices are taken from vertically, this is this plane. This is called sagittal plane. This plane is coronal plane and this plane is transverse plane. So basically the MRI images are supplied in 3 planes. So there will be several sagittal cuts. Sagittal cuts is like this, like this, like this, like this. So this is your sagittal cut. Transverse cut is like this. This is your transverse, sorry, the coronal cut. And transverse cut is like this. So this is your
Sagittal.
This is your
Coronal.
and this is your
Transverse.
transverse. So again, another very important thing is to remember that if I'm taking this is sagittal cut. That is not enough. You have to tell me this sagittal cut is exactly through the midline or little paramedial or more paramedial. That is exactly from where the sagittal section has been taken. And for that, at the corner, you must be having a small image from which will be telling you that at which level this sagittal section is taken and vice versa. That means if I'm telling that this is a transverse section, then again you have to tell the transverse section is taken from which level? Is it to the disc level? Is it to the vertebral body level? If it is a vertebral body or disc, at which vertebral body or disc? And that should be told by a corner. Same for the coronal level. That means only one image is not enough to understand from where the section is taken, which kind of section is it. Okay. So now look at this image. So here, this is your which image?
Sagittal.
Sagittal. And this is your
Transverse.
and you see there is a line here. This line is telling you that this sagittal image has been please mute lot of noise. Please. Okay, so see here, this line is telling at which level this sagittal image is taken. That means, is it from the midline? Yes, this is from the midline because this is your sagittal image. So here, if the sagittal image is taken from the midline, how it looks? You can see these are your chorda equina fibers. These are looking black. You see. So here you can see the spinal cord is ending at the level of the L1, right? Spinal cord do not look that bright white. It's basically dark because spinal cord don't have neither much of fat, don't have any water. So spinal cord looks dark, black, not completely black, but more or less dark because it has some fatty tissues. So sorry. So spinal cord end here, and after that, what is there? These are the all chorda equina. This is basically floating in the CSF, and this is your CSF. So you can see anteriorly. Then this is vertebral bodies. These are the disc, and disc is looking a little bit of not completely black. But you see the annulus anteriorly and posteriorly. This is the annulus. Annulus is tough fibrocartilaginous structures without having much water, so they looks black. You see, so the annulus looks black, but nuclear material looks white. Is not fully white like CSF, but more or less white. So here this section is taken from the midline. Now go to the next slide. Now see where from this section is taken. It is the paramedial areas. Okay. So remember again, this concept is also very important regarding your traversing nerve root and exiting nerve root. So you see here, this nerve root is basically traversing nerve root. So here is the neural foramen. Here is the neural foramen. So this traversing nerve root, it comes here and then it goes next level outside. And with that level, it is called exiting nerve root. So here it is traversing nerve root, and when it will be going into the foramen and outside, it will be called exiting nerve root. So when we are having the section and the paramedial area just inside the foramen, here is the foramen, just inside the foramen, we can see this line is going through this dark spot. This is your traversing nerve root, and you can see here these black lines. So this black line is basically this black line was not visible when it was midline. You see, here there is no black lines. See? Because at the midline there is no traversing nerve root. But when here, please mute, please, a lot of disturbance. So when we are going here, then we can see the next slide. When we are going here, then these black lines are basically your traversing nerve. And then when you are at the level of the foramen, you see we are at the level of the foramen. What you can see? Foramen very nicely. So this image is very, very important to understand the foramen. So you can see the vertebral body, you can see the pedicle, and in between one pedicle to another pedicle, this whole is your neural foramen. So what is the boundary of the neural foramen? Anteriorly, upper part is the vertebral body, lower part by the disc annulus, posteriorly above by inferior articular process, below by the superior articular process, above roof is formed by the one pedicle, and floor is formed by the another pedicle. So this is your neural foramina, and this black is your exiting nerve root. Okay, and these white areas are the foraminal fatty tissues. Right? Remember these things, very, very important. Foramen is the most important structures in the spine. You have to understand it by the CRM image. You have to understand it very nicely on the MRI. So every time you have to understand the foramen very nicely. So foramen, upper floor is formed by the one pedicle, roof is formed by the another pedicle. So whole from this area is your foramen. It is occupied, upper part is occupied by the nerve root. So exiting nerve root is here, right? And whole of this is the foraminal fat. Now this is on the other side foramen. So you can see the other side foramen. Again, this is the nerve root, and this white area is your foraminal fat. Now this section is this transverse section, and on the sagittal image, we can see from where this transverse image is taken. You can see this transverse image has been, little bit of oblique. So upper part, anterior part, but that means this part is your vertebral body. You see, then some part is through the disc here, and some part is here. This part is through the annulus. So this black line is the annulus, and this is your. What is this black dot? Who can say?
SI joint.
This black dot, this one.
Exiting nerve root. Exiting nerve root.
Traversing nerve root. Exiting nerve root will be here because that is outside the foramen or in the foramen. This is inside the foramen. So this is your traversing nerve root.
Okay, sir.
Okay. Now again, you can see this is through that was through the L5S1 disc. This is through the L45 disc, and you can see the annulus very nicely. As I told you. Okay, first tell me what is this image? T1 or T2?
T2.
T2. Why?
T2.
Why?
Because we are seeing the spinal
CSF.
fluid is white.
CSF is white.
CSF is white.
And also you can see the nuclear material is looking white. Nuclear material is white, and your annulus is looking black. And these are your traversing nerve root. Understand? And these black dots are basically exiting nerve root, which has been divided. As soon as the exiting nerve root is coming outside, sometimes you can see the exiting nerve root very nicely. I'll be showing you some pictures right now. But many times exiting nerve root is divided into the ventral rami, dorsal rami, and branches. So they might be seen like this also. So this is exiting nerve roots dividing. That's why it is looking broader. and this is much more compact. This is your traversing nerve root, right? So keep this in mind. So coronal section, sagittal section, and transverse section, and from where exactly it is going, T1 weighted image, T2 weighted image, which one is nerve root, which one is fat, which one is annulus. You have to all understand this very nicely. Okay, another thing I forgot to mention. In this image also you can see the facet joint. So in the CT scan you have seen facet joint very nicely, but X-ray, MRI also you can see. What is this?
Superior articular.
Very good. Superior articular process is from inferior and lateral. And what is this?
Inferior articular process.
And what is this? Is your facet joint.
Facet joint.
Very good. Now look at this. This is a very nice image. So you will be getting this kind of transverse image very often. So these are transverse sections, and you see that each sections there is a line there, and this line here is named as 1, 2, 3, 4, 5, 6. And at the corner of the image, you will be seeing that the image. So you have to match it. That this section, it exactly from where it is taken. Then only you'll be able to understand that which level it is. Right? Now, I'll be showing you some of the image and I'll be discussing. Okay, can you tell me why this image and this image is differing? You can see here is the annulus is very nicely seen. Okay, and here can you see the annulus?
This is body. It's a lower image.
It is through the end plate. You see, there is some images is taken from the end plate, going through the black line. So this black line is end plate. So when the image will be going through the end plate, you will see image like that. You will not be able to identify the annulus very nicely. But when you are at the level of the disc, you can see this is, what is this black dot?
Traversing nerve root.
Very good. And what is this black dot?
Exiting nerve root.
Very good. So this is your exiting nerve root. But in some level, exiting nerve root will be seeing. Please mute. So in some level, you'll be seeing that the exiting nerve root has been divided, right? But in some level, you'll be seeing this, it is compact. And what is this fat, white area?
Epidural fat. This is.
What is this white area?
Ligamentum flavum.
Fat.
No. Epidural fat.
Epidural fat is this one, is epidural fat.
The lateral
foraminal fat. Just now I have shown you in the other image that in the foramen, upper part is occupied by the nerve and lower part is by the fat. So here this section is taken from where you see the nerve root is already coming outside. Here it is exiting nerve root, but this is your foraminal fat. This is your foraminal fat. Here your exiting nerve root is here. See, this is your foraminal fat. Right? So this is not nerve root, this is your foraminal fat. Here you can see the traversing nerve root, here you can see the exiting nerve root. And here you can see the very healthy annulus. So here all the discs are very nice. There is no degeneration. How to know that there is no degeneration? Because you can see the very thick rim of annulus. So what will be the first sign of the disc degeneration? When you will see this white nuclear material is leaking in the annulus, then we call it a degenerated disc. So when you cannot see the annulus marking outline very nicely, and disc is going degenerate, that is called degenerated disc. Blackening of the disc is not degenerated. Here you see this disc is this actually MRI is of a young person, because here you can see the whiteness of the nuclear material. But if you are taking this in a adult, older people, then this whiteness will be reduced. But that is not a pathological disc. That is called aged disc. Pathological disc means when the nuclear material will be coming towards the periphery, because of this nuclear material is leaking through the annulus, that is called a degenerated disc. Okay, clear? So first, what is very important, I always tell, to start understanding the MRI, first store the the normal MRI picture in your hard disk. Then you compare with the the abnormal things. I'll be just skipping these slides. Not, you can see here the exiting nerve root is so big, very nicely seen. You can see this is a traversing nerve root, and here you can see disc is degenerated. You can see because this level, this is taken through the disc level, and here you can see that nuclear material is coming towards the periphery. So disc is degenerated, but there is no pressure on the exiting or traversing nerve root is here. Exiting nerve root is here. The foraminal fat is here, and here again very important. You see the this is the synovial fluid of the facet joint. Not always so nicely seen. This is your superior articular process, inferior articular process, and there is the synovial fluid. So sometimes there is effusion, and this is also a little bit of effusion, and that's why it is so brightly seen. So this is a degenerated disc because the nuclear material is coming to the periphery, but no nerve root compression. So this patient can present with a discogenic back pain because the nerves, sympathetic nerves going inside, they'll be getting, irritated, inflamed because of the nuclear material. So they will not produce any radicular leg pain in this patient because nerve root is very nicely seen. None of the nerve root is getting compressed, right? So this is at the little bit down level where you can see that it is through the cartilaginous end plate. Now here it is pathological. This is your concept of the exiting nerve root and traversing nerve root. You see here, this is your disc, and at this level, the nerve root which is there, that is exiting. So this is your L5, this is your L4. So what is this nerve root?
L4.
L4.
L4,
sir.
only L4 is not a complete answer.
L4 exiting nerve root.
Very
L4
good.
exiting nerve root.
So you should call it L4 exiting now, right? What is this nerve root?
L5 exiting.
L5 exiting.
L5.
L5.
Better answer will be L5 traversing now. That means you see, please mute. That means you see, at the level of the L4-5, you see, at the level of the L4-5, there are two nerve roots. One is here, another is here. One is exiting, another is traversing. So each level, there are two nerve roots, which is coming apart from the chordoichino fibers. Forget about it. The two nerve roots, one is exiting, another is traversing. So you see, exiting nerve root is exiting above the disc. You see, because the nerve root, exiting nerve root is in the upper part of the foramen. Foramen is from one pedicle to another pedicle, and exiting nerve root in the upper part. So normally, exiting nerve root is not getting compressed by that level disc. That means L4-5 disc prolapse normally affects the L5 traversing nerve root here because L4 is already exited. But exception is there. Exception is here, you see, when it is exited, so when the disc prolapse is there, and if the disc prolapse is migrated upwards, then you can affect the. So there are different types of prolapse disc, which I'll be discussing it in the next slide. So here, this is also very important. You see here, if the disc, ordinary prolapse disc, paracentral disc, then the traversing nerve root will be getting compressed. But if it is migrated upwards or migrated far laterally, that is called far lateral disc. Far laterally, then this L4 might be compressed. But otherwise, as a rule, L4-5 disc will be compressing L5 traversing nerve root. When L4 will be getting compressed, if it is migrated up or if it is a far lateral disc. Right? Now look at this picture. So this prolapse can be central. If it is a central, then normally this is your traversing nerve root, this is your exiting nerve root. Normally none of them are getting compressed. If it is a paracentral, this is paracentral disc. So if it is a paracentral disc, then the traversing nerve root will be getting compressed. If it is a foraminal, then it will be compressing the exiting nerve root. And if it is a extraforaminal or far lateral, then will be exiting nerve root again, because it is going like that. Here also schematic diagram. Normally central can compress the exiting nerve root here. Sorry, traversing nerve root. But traversing nerve root is more commonly, this is your traversing, paracentral. Paracentral will be compressing the traversing nerve root. But if paracentral is going up, that is called migrated disc. Then the exiting nerve root will be getting compressed. Or if it is going far lateral, or if it is going that is called the extraforaminal or far lateral, then it is called the exiting nerve root. So exiting nerve root will be getting compressed by two conditions. If it is superior migrated, or if it is a far lateral. And otherwise, it will be compressing the traversing nerve root. And this kind of herniation is the most common kind of herniation. Right? Okay. Now, Here also in MRI, A is what kind of herniation? If it is herniated here, central. B is
Paracentral.
paracentral. C is
Foraminal or lateral.
very good. And D is
Extraforaminal.
or lateral or extraforaminal.
extraforaminal.
Very good. Okay. So now I'll be skipping this. Now tell me, what kind of herniation is this?
This is foraminal.
Foraminal.
Foraminal. Very good.
Foraminal.
And you can see here also in the sagittal view, you can see also the foraminal view. You can see it has been,
Upward migration.
compressing there. So it is a foraminal. Please mute, please. Okay. So now again, tell me, what kind of herniation is this?
Central.
This is paracentral.
Paracentral.
Okay, now another question to you. Suppose this is your L4-5 level. So where will be the pain? Can you tell me? If you are getting this kind of image given to you, this is your, say for example, this is your actually this is your L34. Okay, L34 disc. This is your
L3. L5.
L4.
My question is not that. My question is, getting this image, where will be the patient's pain?
Thigh quadriceps.
High.
Thigh
First you
quadriceps.
tell me what, which side? Right or left?
Left.
Left. So this side is your right side, MRI, this side is your left side. So this is your left side.
This is
Please mute now. So if it is your L34 disc, so it is the exiting L3 will be involved, right? So if it is an L3, where is the supplying the L3? L3 is which part?
Anterior part of the thigh.
Anterior thigh and going to the medial part of the knee.
Quadriceps.
Right? So this will be presented as the anterior thigh pain going up to the medial knee. And this patient can be confused with the knee pathology. In fact, I just have seen this kind of patient which presented with the knee pain only, because the medial part of the knee is supplied by the L3. So this patient can present with the anterior thigh or just simply with the knee pain. Right? Now tell me, suppose this level is L5S1 level. So now tell me how this patient will present. This is called clinical correlation. One very important message you must be knowing, I don't know whether I told you or not, that if you are having an MRI of age more than 50 years, you will be having 50% of the MRI, you will be seeing some kind of prolapse disc. So unless they are matching clinically, they have value, otherwise don't have value. So you have to have the clinical knowledge, how this MRI should present clinically. This is called clinical correlation. You see any MRI report, last line written by the radiologist, please correlate clinically. So this is called clinical correlation. So tell me now, if it is an L5S1 disc, how this patient will present?
S1 is
weakness of left plantar flexors.
So this patient, which nerve root will become getting compressed?
S1 traversing nerve root. S1.
Very good. This will present as an S1 traversing nerve root. So S1 is going to the lateral part of the foot. Please mute now. Lateral part of the foot and sole. So this patient will present on the pain on the lateral part of the foot and the sole. And S1 is also responsible for the plantar flexion. So the plantar flexion will be
Sir, you're muted. Sir, your voice is not audible.
Sir, cannot hear.
okay. Sorry. So what I was telling, that this patient will present as a pain on the lateral part of the foot and the sole. There will be weakness of the plantar flexion. Toe walking will be difficult, weakness. There will be loss of ankle jerk, because ankle jerk is S1, S2. And there might be numbness of the lateral part of the foot and the sole, the little toe. So lateral malleolus. So this area will be numb. So this will be the clinical presentation. Why? Because traversing on which side, right or left? It is the left side.
The left side.
So that is how it should be clinically correlated. But another very important findings in this MRI. Who can tell this thing?
Sir, facet joint is also involved.
What kind of involvement? Can you tell me?
Sir, in this
Right sided fascicular hypertrophy.
Right-sided effusion is there. That means this patient can present also with the right-sided back pain, left-sided leg pain with right-sided back pain. This will be the clinical presentations. Left-sided pain, which is going down up to the little toe, lateral malleolus, lateral part of the foot, and back pain, lower back pain, because of there is some effusion here on the right side facet joint. Very good. Okay, now let us go to the next one. What is time now? I am taking longer time. My God, it is already 8:17. Sorry. Okay, so what is this kind of prolapse?
Paracentral prolapse.
Right paracentral. Right
Paracentral and
Right side
central. So
paracentral.
this patient will present with the traversing nerve root. You know, traversing nerve root is getting compressed. So again, this is on the right side.
Yes.
Earlier patient was on the left side. This patient is on the right. Okay, now this patient again traversing nerve root. You see the disc is degenerated because you cannot see the annulus, and you see this is prolapsed and traversing nerve root is getting compressed. Right? This is another kind of disc. You know, see here it is migrated, and this is called sequestrated disc. The continuity is lost here. So a round shaped, you know, bolus coming downwards. So this is another kind of disc. Okay, I'll be, you know, for today this much is okay. So maybe, you know, if I'm getting some other time, I'll be having another class on the MRI, because, you know, a lot of other things to be discussed, you know, by our other faculties are waiting. So now if you're having some quick questions, you can ask me.
Could you please explain this unstable listhesis?
Okay, unstable listhesis means you have to have an lateral view of the X-ray and have an flexion extension image. If you see that the listhesis part, percentage of the listhesis, as I told you, in the classification, class 1, grade 1, grade 2, grade 3, 0 to 25, 25 to 50. So if you see that the percentage of the, the listhesis is changing with the flexion extension, that indicates this is an unstable listhesis. So unstable listhesis need to be fixed surgically. But if it is a stable one, that means if you are doing a flexion extension, listhesis remains same. It is not changing. The percentage is not changing. That is called your stable listhesis.
Thank you, sir.
Excuse me, sir. Even
Yes.
if the stable listhesis is present, but it is covering 50% or 75%, then in that case, we should send the patient to the surgeon or
no? I told you when to send the patient to the surgeon. Surgeon means one is if the patient is having the neuro deficits because of the bony canal stenosis. I told you there is because of the listhesis, there will be bony spinal canal stenosis. Spinal canal will be narrowed because one vertebral body is moved to the other. So that can cause a nerve damage, nerve root damage, and neuro deficits. In that situation, you need to send. And if there is unstable listhesis, otherwise, if it is a stable listhesis without any neuro deficit, that can be managed by yourself.
Thank you, sir.
Excuse me,
another
sir.
question.
Sir.
Hello.
Yes.
Please, can you please summarize the differentiation between the types of MRI T1, T2, and STEER? Because I didn't get it.
Okay, I have to share the image again. Okay, tell me, what is this kind of image? Okay, forget about this fracture. No, I'm not talking about fracture today. So what is this image? S1, T1 or T2 or STIR?
T1.
Why? Which structures look white in T1? Which structures are looking black in T1?
Only fatty tissue is white.
That is white. And which is black?
Water
I
or
cannot hear.
CSF.
Water is
Water
black.
or CSF.
No. Where there is
I
no
cannot
fat,
hear.
that will be looking black.
Water is black, sir.
Okay. So
Sorry,
CSF
can you
will
mute,
be
please?
black because there
I
is no
cannot
fat,
hear.
right? But remember this way: if no fat, then black. If lot of fat, white. Right? Little bit of fat, it will look gray. And in T2, both fat and water will be looking white. No fat, no water, that will be looking black. Right? Now look at this. This is your T1. Why? Because this is subcutaneous tissue is looking very bright white. posterior epidural fat is looking very bright white. So this is a T1 weighted image. And you can see the CSF is looking black. Vertebral body, as I told you, there are some fatty tissues are there in the bone marrow. So that will be looking gray, not as white as this, but not black as well like this. So it will be in between this black and white. So vertebral body will be looking gray, right? Disc will be looking more black because disc there is no fat. Okay, so this is your T1. T2, you see the subcutaneous tissue is white, epidural fat white, but CSF is also white because it is having water, so it is also looking white, right? So this is what T2. And STIR is same like this, but only thing is your fat will be suppressed. That means only water will be looking white. Let me find out one STIR image for you. Okay, so come here. So see here, this is your STIR. STIR means you compare with this one and this one. This is T1, this is T2, this is STIR. So here the fat was looking white here. See, fat is not looking white here. This was also epidural fat, fatty infiltration, that is not looking white. So just to summarize, T1 fat looks white, while there is no fat looks black. T2 both fat and water looks white, while there is no water, no fat, that will be looking black. STIR, where there will be water, that will be looking white, while there will be no water, that will be looking black. That is your STIR. Is it clear now?
Yeah, clear. Thank you very much. Please, another question. I'm sorry.
Yes.
I want to know the cases for lumbar spine that we have to refer to surgeon. We don't interfere. What are the types of cases that we have to refer to surgeon?
Right now, okay. The best cases is not dependent on your MRI findings. The most important cases where the surgery is needed is not determined by the MRI. As just now I told you what, that 50% of the MRI image remains asymptomatic. Even there is a product, even there is some pathology that remains asymptomatic, so they don't need surgery. So it is whether the patient is having the red flag signs. So what are the red flag signs? If there is a motor deficit, if there is progressive sensory deficit, then those are red flag. If there is autonomic nervous system, that means if the patient cannot pass stool, if the patient is having the retention of the urine, cannot pass urine, so these are the red flags. In this situation, you should send this patient to the surgeon. All other patients, if there is no neurodeficits, you should not send this patient to the surgeons. But for the listhesis, another thing I told you, that if it is an unstable, then also need to send to the surgeon. But as a general rule, because it case to case, it depends, it varies. I cannot tell you in one line which case to be sent to the surgeon. But if I want to summarize that which cases should be sent to the surgeon is if there is red flag. And what are the red flags? If there is a autonomic dysfunction, that means retention of the urine and constipation. If there is motor deficits, if there is progressive sensory deficits, so these are red flags, and these patients need to be referred to the surgeons. Is it clear?
Yeah, clear. Thank you very much.
Okay.
So one question, sir.
Yes.
So please show that
Sir, how
slide
does-
of disc degeneration.
Disc degeneration on MRI?
Yes, sir. Yes, sir.
So what will be the sign? You tell me first.
Sir, I could not differentiate. That disc was looking completely grayish, not exactly
I am asking
black.
you the basic thing that I covered last day, not today. What is called disc degeneration?
Sir, the nucleus pulposus part will start leaking into the 1/3 of the annulus will start.
Which part of the disc is affected by the disc degeneration? This
Sir,
is my question.
annulus. Sir, annulus.
Annulus, right? So
Yes,
how the normal annulus looks in MRI?
Sir, black.
So this is the normal MRI, black rim, right?
Yes. Yes.
So this is the normal disc because we can see the healthy annulus, black rim of annulus. Okay, so this disc is not degenerated.
Okay.
But you see, this is the another disc. Okay, here you can see you cannot differentiate the annulus. Nuclear material is spreading to the periphery. So this is a degenerated disc, right?
Okay,
so this is a degenerated disc. You can see that this material is spreading towards the periphery.
Okay, okay, sir. Yes. Thank you,
You
sir.
cannot demarcate the annulus. That is
Yes,
your
sir.
degenerated disc. Degenerated disc is not equal to prolapsed disc. Sometimes
Yes,
it is
sir.
getting prolapsed. It depends on the grades. I show you the Dallas classification. You know, the grade 1, grade 2, grade 3. Normally grade 4 and grade 5, either disc is bulged or disc is extruded outside. Then only there will be prolapsed disc and radicular pain. Otherwise, there will be no radicular pain. There will be only
Yes.
back pain. If the disc is degenerated, patient will present with leg back pain. But when it will be prolapsed, it will compress the nerve root. Then that will produce your leg pain.
Leg
So
pain.
this disc is degenerated as well as prolapsed.
Yes, sir.
But sometimes there is no prolapse, only degeneration. Is it clear now?
Yes, yes, sir. Thank you, sir.
Okay.
Sir, which portion of this in this picture, sir? In some MRI, we see compression of the lateral recess. And what is the importance of compression of this lateral recess?
Lateral recess means, what is lateral recess?
Sir,
It
sir,
is
confused.
paracentral.
No, my question is, what is called lateral recess?
Foraminal area.
So where is the foramen? Foramen boundary is, this is your posterior boundary. You can see this is the foramen, no? So
Yes,
this is
sir.
the posterior boundary, this is the anterior boundary. So posteriorly by the superior articular process. And above it is your inferior articular process. And anteriorly, what is there? Above is your vertebral body. I show in the other picture of the MRI. Above other part by the vertebral body, lower part by the disc. So
Yes, sir.
this mouth of this starting point of the foramen. So foramen is from here to here is the foramen length. So the
Yes, sir.
starting point of this foramen is called the lateral recess. Okay. So
Okay,
in
sir.
the lateral recess, there is traversing nerve root. So you see the traversing nerve root is in the lateral recess. So in the
Lateral recess.
paracentral recess, this is your paracentral prolapse. You see this is the paracentral prolapse.
Yes,
And
sir.
it is compressing the traversing nerve
Lateral
root.
recess.
That means if there is a prolapse in the lateral recess, that is normally by the paracentral herniation, and that causes the traversing nerve root compression.
Okay, sir. Okay, sir.
Is it clear
Sir,
now?
yes, sir. Completely clear. Another question, sir. Last question, sir. That how does our level of intervention change with the sacralization and lumbarization, sir? It is very confusing that if there is a sacralization or a lumbarization, how should we decide that which level should be?
Sacralization, lumbarization do not tell us which level to be done. You have to clinically understand where is the patient. Suppose whether the pain is going along the medial towards the great toe, or it is going towards the lateral side. So if it is a L5 nerve root, you have to choose the L5 nerve root, either traversing or exiting nerve root. And you have to understand where is the traversing nerve root and exiting nerve root, depending on the level of the, you have to understand the level, depending on sacralization or lumbarization, and then appropriately you have to choose it. So the answer is not a shortcut answer. First is clinically you have to understand which nerve root to be blocked. Second important point, whether traversing nerve root or exiting nerve root. That means suppose if I am planning, forget about the sacralization and lumbarization. I am planning to block an L5 nerve root block or L5 nerve root injection. So at which level should you give? At the L4-5 level or L5S1 level?
L4-5 level.
Any other answer?
It is at the
L5
L5
S1.
level.
L5 S1.
But my answer is both the level. I can go in the L5S1 level or I can go in the L4-5. Are you happy with my answer?
Yes, sir. Yes, sir. Yes, sir. I understood, sir.
Sir,
Yes.
please
Why?
briefly discuss your answer.
Okay, I'm just showing this picture. So as I told you, this is your L4-5 level and this is L5 nerve root, right? So if needle is going like this, inferior part of the foramen, that is called Cambine's triangle approach. Upper part of the is called your subpedicular approach. If I'm going the Cambine's triangle approach, I'll be targeting the L5 traversing nerve. So I can go at the level of the L4-5 if I'm going like this. Or another is, this is your L5S1 level. If I'm going subpedicular approach, then I can go at the level of the exiting L5 nerve root. So L5 nerve root can be blocked both at the level of the L5S1 or at the level of the L4-5, depending on whether I'm targeting a traversing or an exiting one, right? And now also you have to determine that which level on the image, you have to understand that whether this is L5, S1, depending on your sacral. I told you at the beginning, you have to understand the level by looking at the 12th rib, by looking at your ala of the sacrum, by looking at the highest point of the iliac crest. So all these points will be telling you that which one. Still, sometimes it becomes difficult. But all these points you have to correlate nicely. You have to count from above, you have to count from below, and then you have to understand whether this is L4, whether this is L5, whether this is S1. In that way, you have to understand which nerve root to be blocked. Right?
Yes, yes, sir. Thank you so much. Thank you so much. Understood, sir.
So, in a T2 weighted image, in the midline sagittal section, would the disc appear white, or I think it should appear a bit whitish because it has got fluid inside it. But I thought the slide showed it as a bit black. So
if it is showing black, that means what does it indicate? T2 sagittal image. Okay, I'm just showing you the T2 sagittal image here. Okay, so this is your midline T2 sagittal image. Okay, what are you asking?
So in case of a T2 image,
this is T1 or T2?
Yeah.
This is T1 or T2? This is T2.
T2.
Isn't it?
T2. Yes. T2.
Now, what is the question? It is midline sagittal. This part is your midline
so,
sagittal.
Yeah, it does appear
what? What are you asking?
No, it does appear a bit white. I thought it looked a bit black. So thank you.
If the disc looks black, that means the disc is dehydrated.
Dehydrated.
Degeneration you cannot tell. Means, as I told you, older person disc gets itself dehydrated. But whether it is a degenerated or not, you have to understood by looking at the annulus. If the annulus is very nicely seen, that means it is not degenerated. But if the annulus is not nicely seen, then it is degenerated.
Thank you.
Right? But if it is looking black, means it don't have water. But you cannot tell whether it is degenerated or not. Degenerated means whether the nuclear material is leaking towards periphery then or not.
Thank you.
Right?
Yes, thank you.
Okay, so shall I stop now? Because other part is there, already it is 8:30 and more. I feel so sad, when people starts leaving. We are taking so much of pain to answer all your questions, but still we see that a lot of people are leaving. If you see that, okay, a lot of we lost our motivation. That okay, people are not liking our lectures. They are leaving the meeting. Because we never look at the watch whenever we are, all our faculty are like that. All our faculty, they try to answer your all and each and every questions. But it is your humble request to you, when you are taking so much of pain, talking so much just to answer your question, you should not be leaving the meeting. It is only 73 people, and registered participants for this batch is more than 100. So this do not looks nice. But as I told earlier, right now, all the time, that we never look at our watch when we are delivering lecture, and we try to answer all your questions. But right now, I think we should go to the other part. Debjyoti and Chinmay are wishing there, and they'll be starting the other part. Okay.
Hello.
Yeah. Yes. Yes.
Sorry,
Debjyoti, Chinmay, start now.
Okay. My slide is visible, isn't it?
Yes, yes, yes.
Okay. So the same thing, Dr. Debjyoti has already shown that how to do this one, SI joint injection and caudal epidural. Okay, how to do caudal epidural and SI joint injection under ultrasound. And I also tell you, will show you that how to do it under fluoroscopy. So S1 transforaminal, SI joint injection and caudal epidural. Please, all of you mute, otherwise it is very difficult. Okay, so this is a CT reconstruction of our sacrum. So here in CT reconstruction, we can see that this is the posterior foramens. Okay, so and these are the spines. And here, when under the X-ray, we can see this is a two-dimensional picture of a three-dimensional structure. So from here we have to understand that which structure is what. So here there are two lines, one is medial line and one is lateral line. And main thing, this is the SI joint is a diarthrodial joint. Okay, since it is a diarthrodial joint, means it is a plate, like one plate above the other, and some part is covering the other part. Like if in the middle part sacrum is there, and iliac bone that comes and covers some part of the sacrum. Okay, so what will happen then in that case? The posterior joint line, this medial one is the posterior joint line, and this and lateral one is the your anterior joint line. So when you see this, you may feel that both the lines are at the same level, but these are not at the same level. When the patient will be prone and we are injecting from the back side, then no way we can enter in the anterior joint line. We have to enter in the posterior joint line. Okay, so we will target this part only, this joint line, and this joint line we cannot target. Okay, and then the joint lines that also we will target the lower one third of the joint line, not the upper one third, upper 2/3, mainly lower 1/3. Why? Because with time, with age, I mean, the upper part of the joint become fibrous, and there is no such space where you can inject drug. So lower 1/3 of the posterior joint line is our target point. Okay, with ultrasound, of course, we go in the upper part of the joint line, and that is difficult to inject. But then with X-ray, we go, just remember, posterior joint line and lower 1/3. Okay, so this will be SI joint, about the SI joint. Okay, and then these foramens are also in the same way. These foramens are both the foramens are here. One is anterior foramen, one is posterior foramen. Which one is anterior and which one is posterior? So these beautifully looking foramens, if you think that just a minute. So okay, if you okay, if you think that this is a foramen and this is a foramen, then you are mistaken. That these are foramens, but these are anterior foramens, and you can never reach to the anterior foramen in a prone patient going from back. So you have to go to the posterior foramen. So I show you. So these lines are anterior foramen lines, anterior foramen lines, anterior foramen lines, anterior foramen lines. Okay, so where is the posterior foramen lines? So posterior foramen is somewhere here. Lower one. Okay, they are also. No, wait. Okay, this one is one foramen. These are the posterior foramen. Here also, this upper one, you can see that this is the posterior foramen. So it is a bit difficult to see, but we can see. Okay, so for S1 transforaminal, we will go to the S1 foramen or S2 foramen, whichever transforaminal we are going to do. We will go through that foramen, but the posterior foramen, not the anterior one. Okay, so let us go to the next slide. So here we can see. So you can see that. Okay, these are the foramen where the anterior and posterior are overlapping. So you can see this is a margin of one foramen. Okay, so this is the posterior foramen, and the beautifully looking foramen is basically the anterior foramen. So here is also same thing. This is the anterior foramen and this is the posterior foramen. So our target is this part. Of course, if we put your injection in this part, then also you will be able to give injection. But then we always try to position our X-ray in such a way that both the foramens come in the one line, and at least this part is in one line. Okay, we will target this area. Okay, so this for here, when the this left side of the picture, here you can see that when at the starting point, when we do a AP picture, just to first take an AP X-ray picture of a prone patient, then probably we will see this picture where these anterior foramens are much easily seen, and posterior foramen you can see it is much above. It is much above. Okay, and then we will make our C-arm a bit oblique so that this foramen comes over this foramen comes over this, and this picture we will get. Okay, we will get this picture. So so this is the so this was, I was telling that first AP picture, then we will do a craniocaudal tilt so that the both the foramens come in same line. This one foramen and here will be another foramen, they are coming in the same line. When we will be seeing a AP picture, we will be seeing like this. Okay, so that is not intended. I mean, for injection, that is not the perfect position. Okay. So here you can see that our in this patient, this is the L5 under the L5 pedicle, a transforaminal injection is being given, but another needle and the below one is in the S1 foraminal level and in the epidural space. So here also the same thing, same picture, lateral view and AP view. These AP view, you can see both the foramens are at different level, not overlapping each other. Okay. Here you can see actually this foramen, most like this foramen is actually the S1 foramen. Okay, and the posterior S1 foramen, and this is the anterior S1 foramen. Okay, so this lower anterior one is more clearer, but that is not our target. Okay, so after putting your needle in the foraminal level, when you inject contrast, then the contrast should go above towards the epidural space along with the nerve root. Okay, this is also after giving contrast. This is also after giving contrast. A more contrast is given, so we can see that it is going towards the epidural space. After giving contrast, we can see that contrast has given in the gone in the intravascular distribution. This is an intravascular distribution, though it is not a simple X-ray picture. This is a DSA picture. Okay, so here we can see that how but this is under, of course, in the under L4 actually. So at this level, but you should know that while giving injection, some drug contrast may go intravascular. Okay, it is in the S1 level. So here intravascular distribution, we can see it is a X-ray picture just after giving injection. The when you gave contrast and we took the I mean like fluoroscopy shot, then we saw this picture. So needle has to be repositioned, and mind it that aspirating with a syringe is not always positive. You aspirate, no blood is coming, that doesn't mean you are not in the vessel. If the vessel is smaller, then nothing comes, blood doesn't come during aspiration. But if you inject contrast, this type of picture can come. Okay, this type of picture in the caudal epidural. This is a caudal epidural injection intravascular picture. Hey, Sanjeev. So intravascular picture. Okay. This needle is put there, but then injected is coming backward through the foramen, okay, not going inside in the epidural space the way it should get distributed. Okay, so
Hello.
this is hello. Yeah, someone wants to ask me something. Okay, so this contrast is not correct. So we have to always be sure that when we are giving S1 transforaminal epidural, ultimately it is an epidural where through which you are giving S1 nerve root block also we give. So if it is an epidural and you want epidural spread, then by giving contrast, you should see that spread is all right or not. Okay, caudal epidural. I'm not going into the theory part. So here the same thing, we know that where is the caudal canal. This is the caudal canal. Okay, so so here also you can see the same thing, caudal canal. You can see this is the caudal canal. Okay, so through which we will enter. So how it looks. So here the outer plate and inner table of this your S5, S4, those you can see. So this epidural space you can see very clearly in the lateral view. This is a CT picture. This is a CT cross-section picture. So the same thing comes in X-ray also. I will show you. So in AP view, of course, the needle will be in the midline position. In AP view, we will see that needle is going in the midline position, and we can go up to the S2 foraminal level if we are doing under X-ray. So this is the starting of the needle. If this needle can go up to this much. Okay, here you can see one foramen clearly. Here you can see one foramen, and upper foramens are not clearly seen, but then it is a picture only, maybe these parts. So up to this much, up to S2 foramen, you can go. So this needle is going above, and you can see that needle is going like this. So everything you have to see during your injection. Sometimes what happens, this needle goes like this and comes out like this. Okay, so this is very common in adult. I mean, when we are doing caudal epidural. In children, epidural is very easy, but in adult, many times this needle can come out like through another foramen. Okay, or it can sometimes when we are relying on a loss of resistance type of feeling, that we will puncture this membrane, sacrococcygeal membrane, and we'll feel that I mean, like we are in the space. But sometimes after with X-ray we see our needle has gone here. Okay, that is very common. We as needle has gone here and not here. So very clearly you have to see that you should be in the must be in the epidural space. Okay, then patient is in prone position for most of the procedures. So here we can see very clearly epidural space, you can see. So this is the epidural space, no? So this is also a contrast injection. So here we can see that injection, this injected drug is coming out through anterior foramen. These are coming out through anterior foramen. And I mean, like ultimately contrast is not going up. A lot of drug has come out through anterior foramen, which is not expected. We don't want at least. So here these are called cotton ball appearance. We will see when you are not in the space and you are in the upper soft tissue. This is a vascular distribution vessel inside the vessels. So as time is passing, there is no question of assumption that I have put in the right place and drug will go. So where drug will go, you have to see. There is nothing, you should not assume anything. So needle tip is going there, and then you give contrast, and then you must see that it is spreading above, because you are most likely doing something for L5S1 disc. So here is the disc. So your drug should go like this, okay, and it should spread like this, okay, it should spread like this, far tree appearance, okay. So that thing you must get, and bilaterally symmetrical. If I mean patient has both sided symptom, most of the time for caudal epidural is given when both sided symptom is there, and we will go through any foramen, S1 foramen, S2 foramen, when unilateral symptom is there. Otherwise we can go to through both S1 foramen also, that is also possible. So this type of spread is not acceptable. Then this spread, you see, this is though I mean look, this is not through epidural, this is just to show you that how it looks when contrast goes inside the subarachnoid space. So if you enter through the if your needle comes too much inside, from here needle will come, and it will, if up to S2 foramen you can be there, but if somehow your needle goes above, or you are not above, you are in the right place, but patient have some anatomical differences, like I mean different anatomy is there, can be there in every patient, many patients. So there is I mean the dural sac is much below and you have punctured, then this type of drug distribution you will get. So this type of drug distribution you will get. This is in the subarachnoid space. Next, this is a small subdural spacement. What is subdural? In subdural spacement, what happens? Only a small amount of drug will go so much high, high above. Otherwise, subdural is a potential space in spine. It is not like in our head. Head subdural hematoma is common, but here to catch the subdural space is very difficult. But then inadvertently it can go. So it is a subdural spread, and this type of spread is not when you are giving the injection, that is also not for assumption. I mean how it is spreading, there may be a post-operative case, one time operated, two time operated, or three time operated, then you are giving a drug but it is not spreading equally towards both side and bathing the all the roots. It is going to some route and not going to other route, so this is not acceptable. Okay, so this is also thing. After giving injection, one side is not at all there is no contrast spread. So these are different okay. This is the right spread. This is a very nice spread. Okay, so if you want L5 S1 or L4-5 disc degeneration pain for something you are giving, so this spread is expected. Okay, I mean acceptable. So this is anterior epidural space, it is going in the posterior epidural space, so this is also acceptable. Okay, so these are acceptable. I will not show much here, and most of the time, so this is the most beautiful picture, but of course this is a lot of contrast has been given, and that's why this beautiful picture has come. But some of course this is a picture from epiduroscopy. Epiduroscopy was being done, so a lot of contrast has been given, and some fluid will pass through the anterior foramen, that is expected in epiduroscopy. Okay, so I showed you this one. These are not needed. SI joint intervention, as I told you, the these are SI joints. I mean anterior line and posterior line, you have to understand. The medial line is the posterior line, and lateral line is the anterior line. Okay, so we will target the lower one third, and this SI, when you are doing an SI joint injection, try to see how is the SI joint. We must see the SI joint margins. The margins are irregular, means there is sacroiliitis. These margins are so much regular, so there may not be a sacroiliitis. Okay, but then there are other fatty changes, that is different. So anyway, here also you see these margins are these are the posterior joint line, this is the anterior joint line. We will target in the posterior joint line, and here many other things are there, but then this joint is sacroiliitis is there, margins are bloody margins. Okay, when we do oblique, contralateral oblique, then both lines come one above another and it looks like this. We target here. Okay, our needle will be like this, and then we will give contrast. Contrast will spread like this. Contrast will spread like this. Best picture. Sometimes it doesn't spread so well because its capsule is torn. Contrast doesn't spread so well, but then these are contrast spread, and we can. So this is the best contrast spread. I have shown you the best. This is the best contrast spread. This you can see the whole joint is. I mean, margin is shown. And someone was asking that time that if we can give injection to the periarticular injections in a SI joint arthritis for diagnostic, in case of diagnostic block. Of course, the nerve structures, this is the lateral branches of nerves. You can target the lateral branches for a diagnostic injection. We go, there are different techniques are there. Of course, this is not needed. Okay, then I stop sharing and we will go for demonstration. Today it is too much late. I will make it fast. Okay. So okay, everything what I'm showing. কোথায় চলে গেল? কোথায় আসলো এটা? ও আচ্ছা, নিচেরটা উল্টাপাল্টা কি করেছি। Okay, can you all see the X-ray and mannequin both?
Yes, sir.
Okay, so I show you first the SI joint injection. Okay, so SI joint just with more part of picture মানে আরো বড় দেখতে লাগে। Okay, so here I show you which side is which side. First I see that which side is which side. Shoot. So okay, right side of your screen is the right side of the patient also. I mean, here it is mannequin, of course, but right side of the patient also. So here I will target. We can see both the lines. One is this is the anterior line, which is nicely seen, and another line will be posterior line. Should okay, so this part is the posterior line. Okay, I will make both the line overlapping each other. So do it like this. Okay, this is contralateral oblique. Just try to see that I am moving it obliquely. Okay, you can see now. You can see, I think I am doing the procedure in the right side, but my X-ray is going towards contralateral oblique. Okay, so this is a contralateral oblique, and you see the lower part of the joint is becoming clean, more cleaner. Okay, so lower part of the joint has become white. Okay, why it is white? Because there is no soft tissue here. It is a mannequin, and as soon as both the joint line will come over each other, it will become clean white. Air will be passing through this. Okay, shoot. So it is expected that okay, I will make it a bit middle position. Yes. Whenever we go to any target any position, the place where we should inject, that should be in the middle of the screen. Though here also it is not in the middle of the screen, but we should target in the middle of the screen. Otherwise, parallax error, it is called parallax error, can occur. You are thinking that you are going in the tunnel view, but you may not be going. That is what. Okay, shoot. So it is nearly now middle of the screen, and I am going for tunnel view from the opposite side, from this side to from left side. I am going obliquely towards right SI joint. Okay. So you see, I am already in the joint. Okay, and
Excuse
here
me, is it,
just
right or left SI joint?
This is the right SI joint. Patient is prone. This is the right SI joint, but my oblique will be in the contralateral side. Oblique. It was in contralateral side. I made it contralateral oblique position. Okay. Lateral is not needed. Oh, এটা তুমি এটা একটু ক্লিন করে দেখানো দরকার ছিল, মানে ওই তোমার কন্টিনিউয়াস মেরে একটু একটু এরকম করে দিলে ভালো ছিল। Okay. Okay, in lateral side it is very difficult to understand that where it is in the SI joint, but I will make a bit like continuous, under continuous X-ray I will show you that it is in the joint, you can understand. Okay, just yes, see, it is in the which joint line? It is in the posterior joint line. Okay, sometimes it it is going opposite side. That's why both joint line are different. Now both joint lines are different. Just wait. Yeah, just draw, annotate both joint line. So this is one joint line Dr. Devjyoti has drawn. This is posterior joint line, and this is by red, this is anterior joint line. And when we made contralateral oblique, I am going into right side, but my X-ray is turned to the left side. Okay, so then both the joint line became one above another. একটু continuous করে আবার এদিকে মেরে দাও আর একটার সাথে মিলিয়ে দাও, বাস শেষ। হ্যাঁ, just এদিকে more bas done. Okay, shoot. So you have seen how joint line came one above another. So this one was for SI joint. Okay, now I will go for S1 transforaminal. Just shoot AP. No, just AP. So S1 transforaminal, we will show you the anterior foramen and posterior foramen both. আরেকবার শুট করো তো, সুন্দর হয়নি এটা। Okay. So Dr. Devjyoti will draw. This is the posterior foramen, small foramen, and big, nice anterior foramen we will see. আরেকদিকে এঁকে দাও, নিচে যাও। So the anterior foramen, our target is posterior foramen, not the anterior foramen. Okay, so I show you again here. Just shoot.
This is on same side, sir.
This is okay. I show you in the same side. This is no, earlier I was doing in the right side. Now I am doing in the left side. Okay, I am doing in the left side. Okay, shoot. Okay, shoot. Okay, see this small foramen. This is the posterior foramen, and the S2. Yes, this is S2 foramen, and I was showing S2 only, and then above. Okay, this one is S1 foramen, this small one. Shoot for our. Okay, so you understand these small foramens are posterior foramens and not the bigger one. So now I will make it a bit oblique so that one foramen comes above another. Okay. This is the cranial tilt. I am giving cranial tilt. Okay, so you can see small part of the foramen has come. In S2 you can see very nicely. Just I am showing you. Shoot. See, in S2 there is a small area which when both the foramens over each other. In S1, the right side is more clearer. Shoot. So this is very, this can, shoot. Yeah, so you can see that this small elliptical shape of white color, this is basically due to overlapping of each other. Okay, left side it is not very clear because it is our mannequin, no? So everything cannot be that clear. But then I am going, yeah, shoot. So I will go in the S1 foramen in the right side now. In the foramen in the tunnel view approach. So this is our tunnel view approach, but then actually, okay, shoot. I entered a bit low, that's why. Shoot. Okay. Okay, shoot. So this is a tunnel view approach, and I am in the S1 foramen. So how I will show you lateral. I will show you in the lateral that where I am. Okay. So I am just above the posterior plate of the sacrum. So I'm just going inside a bit. So now I'm in the epidural space. Yeah, now I'm in the epidural space. Okay, sure. So okay. So now I'm in the epidural space. Okay. So this one is the. Okay, shoot. Just yeah. I will show you the caudal epidural now. So caudal epidural from the first starting point, I will show you the. I just want to see the midline. My needle has to be in the midline. So that's what I just want to see, that whether I am in the midline or not. So this marker is in the midline. Okay. Okay. This marker is in the midline, and I can see clearly the hiatus, sacral hiatus. So this is the sacral hiatus. Okay. So I will be entering in the sacral hiatus. How? Just after going up to some portion, when my needle becomes a steady, then yeah, should. Oh, yeah. Okay. Okay. It is in the straight line. So now I will make it lateral. So many times I have seen that if you, I mean, like before seeing lateral, if someone thinks that, okay, this is so easy, I can do. So many times what happens, this needle goes like this. Okay, sure. Needle goes like this, because in human, I mean, like in a live patient, we sometimes miss. Okay. We find there is a loss of resistance in the above portion also. So we now must go in the this epidural space is not very clean. Should. Okay. Okay. Should. Okay, so here it is our mannequin, so epidural space is not that clean, but then in a normal human you will get, of course, a much more cleaner epidural space, very easy to understand. But here also you can understand it clean, that posterior plate, posterior table and anterior table of the sacrum, and so between them the epidural space should. So we can go up to this much, say just below margin of the S2, just below the margin of the S2, and there when we are sure that you are in the epidural space, then we will see again in the epi view that we are in the midline or not. If you want to give injection in one side for certain case where the symptom is unilateral, that is different, but otherwise most of the time it is bilateral and we want to give injection in the midline. So our needle is in the midline. So it is the last position of our epidural, caudal epidural. Okay. And as I mean, many questions was there that why I mean, like which one is the ultrasound or X-ray, which is better? So I will say that X-ray is better because at this position, after you have the option to give contrast, so that your there is, you don't have to assume that how it is spreading. You can see that how it is spreading really, and which nerve roots are getting I mean, like are bathed by the your drug. So that is the most important thing. And ultrasound is used only for you can see that it is office-based practice. If someone has a small OPD-based practice or office-based actually, so in that case, huge C-arm you cannot install anywhere, but ultrasound you can use anywhere actually in small place. So that is what. And okay, any other question, or we can. Let's see. Any question? Anyone? Speaker.
Yes, Chinma, we can hear you.
Okay. So I think no question. Everyone has understood. Sir, we can conclude, I think.
If there is no questions, we can conclude. But before conclusion, I want to announce one thing, that tomorrow from 7 p.m. already I have shared the flyers for tomorrow's program. It is the role of ultrasound in management of back pain. So tomorrow, very important session is there, and all our faculties like Dr. Debjyoti, Dr. Chinma, Dr. Kanchan. Apart from these three faculties, there will be Dr. Jesnu, Dr. Javed. So all the different aspects of the back pain, like facet joint, SI joint, the muscle, myofascial pain. So all these things will be included in the tomorrow's session. So I'll be asking all of you, and your friends also can join, because this is a free session organized in association with the Asculap Academy and Darodia, the pain clinic. So tomorrow at 7, please join, and it will be wonderful discussions waiting for you tomorrow. So in the WhatsApp as well as the Telegram group, I have posted the flyer. So this flyer is a PDF flyer, and there is a link. If you are clicking, you'll be directly joining the meeting. Tomorrow, remember, tomorrow 7 p.m. onwards. I have shared the flyers in the Telegram group as well as your group, your third batch of Asculap Academy. You open your Telegram group. I have already shared there.
Actually, for this batch, only Telegram group is there. So a lot of people are asking why please add me in the WhatsApp group. So previously we have
I have shared it both in the Telegram as well as WhatsApp group.
All the batches, the students of this batch are in the Telegram, not in the WhatsApp. So they are thinking there might be another group in the WhatsApp.
Thank you, sir.
Okay. For this batch only there is one group, that is in Telegram.
Okay, someone wants to see that anterior line. And
I want to ask one question.
Yeah, please tell me.
Sir said for L5 nerve root transforaminal injection, we can approach at L4, L5 level or L5, S1 level. I want to ask at L5, S1 level, the approach is through safe triangle or through Camby's triangle, which is more appropriate?
You tell this. You try to answer this question.
Cambridge triangle is better.
Yeah, sir, you said Camby's triangle is more safe in previous classes.
More safe, but what I told you, that L5 nerve root can be accessed by two approach.
Right.
By
Sir.
Cambian's triangle at the level of the L4-5. This is preferable because this is safer. But it can also be accessed through the L5S1 level. And you know when it is done? If you wish to do a dorsal root ganglion block or selective nerve root block, you have to go L5, you have to target the L5 nerve root at the level of the L5S1. So what I wanted to tell that one nerve root can be targeted, accessed by two approach. By the Cambian's triangle approach, that means you are targeting the traversing nerve root, or by the safe triangle approach, that means you are targeting the exiting nerve root. Same nerve root, you know, like I tell that, okay, the river Ganges, starting from, you know, Haridwar, Rishikesh, if you are placing a, giving a dam, you can block it at the level of the Haridwar, or you can block it at the level of the, you know, the Calcutta. So because it is same nerve root, you can block it there, or you can block it there, more proximally or more distally. Is it clear?
Okay, sir. It's clear, sir. Thank you, sir.
Okay.
Okay. Yeah. Sir, someone wants to see the anterior joint line and posterior joint line again.
Okay. So, and I want to send this message to our, you know, to the participants. You see, our faculty, even if it is time is, you know, 9:17. You see, our faculty are not tired. We all are there for answering all your questions. You can anytime ask any question to our faculty team. We all are ready to answer all your questions. We never look at the watch.
Okay, so sir, they can hear me, no? Or see
yes.
Okay. So just see, this is the SI joint. Okay, so sacrum. This is the sacrum, and this is the iliac bone. Okay, so this is a diarthrodial joint. So some part of the iliac bone is covering the sacrum like this. Okay, covering. So what will happen? This joint will become a plate-like joint. This type of a plate-like joint. So here at this my fingers ending, there will be one joint line, and this fingers ending, there will be another joint line. So that is what is called anterior joint line and posterior joint line. So if I am lying like this, so there is two joint line. One is at the end of this finger, and one is at the end of this finger. Okay. So from the posterior, you can go to end of this finger only, not at this end of this finger joint line. Okay. And the whole thing is the joint. The whole thing is the joint. The same thing. So now as we are seeing the SI joint in a two-dimensional picture. The three-dimensional structure we are seeing in a three-dimensional, two-dimensional picture. So where is the anterior joint line? I show you again. Okay, just shoot once. Not that, that side. Okay. So this is clear. So this is the joint line of the patient is lying prone. Hey, okay, patient is lying prone, and in the right side SI joint I am showing. So this is one joint line. Okay, annotate. So this is one joint line. Okay, and
lateral, posterior.
And this is another joint line. Okay, so this lateral one is anterior joint line. This is the anterior joint line, and medial one is the posterior joint line. So we can enter only in the posterior joint line. Anterior joint line you cannot reach from back side. Okay, so our consideration is only this joint line, but we do such a positioning so that this part of this line and this part of this line comes over each other. Okay, so I will show you just so we will do contralateral oblique. This side I am going to inject. Okay, right side of the patient. This is a prone patient, right side. But you see the C-arm is going in the opposite side. Okay, so C-arm is going to just now you just focus on the anterior joint line. Okay, focus on the anterior joint line. I again show you the anterior joint line. No, posterior joint line. Focus on the posterior joint line. Okay, so this one is the posterior joint line. So focus and just see how the contralateral oblique positioning under continuous X-ray, how it comes over each other. Just shoot. I2. So lower part, you see, so lower part has become white. This part has become so white, means where is that annotated? Okay, this part has become white. What is this structure? This is nothing, because two joint line is one above another. There is no bone, so this is becoming so much white. This joint line has come like this, and this joint line has also come like this. Okay, so I have shown you the but this is clear or not?
Yes, sir.
There is yeah, so just to remember one thing, medial line, we want to target the medial portion, medial line, and the lower 1/3. Okay, so that is one point, and second point is to make it overlap both the lines. You have to do contralateral oblique. If your target is right SI joint, your obliquity will be towards left. Yeah, that's it.
Sir,
Okay,
can you please again show the procedure of this SI joint injection?
Okay.
Please, sir, please, sir.
Okay, just again, AP. If there is any confusion, they should not have. Okay, should be. Okay, again see anterior joint line, posterior joint line. Okay.
Anterior joint line is lateral, posterior joint line.
Yeah. Yes. This is anterior joint line, anterior. This is posterior joint line. My target is here, posterior joint line, but still I will not directly go here. I will make both the lines overlap. Okay. So now overlap. I am doing contralateral oblique. My target is in the right SI joint, but C arm will move in this way, in
Left
this
oblique.
way. Yeah. So shoot. Okay. So our both the joints are actually it is overlap now.
More oblique.
I will make it in the center of nearly center of the screen. A bit more. So it is in the center of the screen. With less. Okay. Okay. So I show you again. Yeah, sure. Okay. So I'm entering here, and I will go directly. Yeah, sure. So I'm in the joint actually. So in mannequin, I cannot show you. This is the way, and when you go inside the joint, you can understand a loss of resistance. AP, just AP. Loss of resistance, but that is not felt in mannequin. So, in AP view, you will see like this. You can see the anterior joint line is a bit lateral to the posterior joint line. So that is okay. And then when you give contrast, the whole joint line, both anterior and posterior should be, contrast should spread. Okay. So I think now
how much of depth we have to go? We have to see in lateral view or just in AP view? You have to confirm.
This depth thing, as soon as you enter, you will feel a loss of resistance. And then when you give contrast, it should spread. Sometimes after getting the loss of resistance also, if you give contrast, it doesn't spread well. Then you have to manipulate a bit, go a bit front or come back a bit, so that your contrast should spread inside the joint. That's it.
Okay. Thank you, sir.
Welcome.
Sir, I want to ask at which group we can ask our queries after the class.
For queries, there is one mail, no? We already shared. We already shared. I will again write in the Telegram that email ID. In that email ID, you write and we will answer. Okay. And otherwise also.
Excuse me, please. Yeah. We need to see next time the interventions of shoulder.
Interventions of shoulder. Okay. I will put the videos. Okay. I will put the videos in Telegram also. Okay.
Okay, sir. Okay, sir.
Okay, thank you.
Thank you, sir.
Okay.
Okay, I hope all the questions has been answered, and now we can end today's session. It is a marathon session, so we exceeded almost 2 hour session is almost 3.5 hour session. So can we end? Only now,
Yes, sir.
even less than
Yes,
half
sir.
of the
Yes, sir.
participants are
Please.
staying.
Yes,
Yes,
sir.
sir. Thank you, sir.
Thank you so much,
Very much,
sir.
sir.
Thank you so
Okay,
much.
okay.
Thank you.
And
Good
those who are
night.
staying here for long 3.5 hours, I'm really happy to see at least 39 people, staying for so long session. And we really see, if we see that our participants are enjoying our lecture, we also enjoy delivering more and more lecture. So it's basically, give and take. If you
Yes,
understand
sir.
our lecture, accept our lecture, if you enjoy our lecture, we also enjoy delivering lecture.
Thank you,
So
sir.
let us end today's session,
Thank
and
you, sir.
let us see and remember today's session, tomorrow's session. Tomorrow at 7 we'll be starting ultrasonography in back pain.
Thank you, sir.
Thank you, sir.
Thank
Thank
you.
you, sir.
Good night.
Good night, sir.
Good night. Good night.